We are going to have a few talks. I will request Dr. Shilpi Shah and Dr. Sudipta to please chair the session.
Good morning. For the second day of this Golden Jubilee of Nayandeep, the first session starts with a talk by Dr. Harsha Bhattacharya, Surgical and Anti-VEGF in Retinal Vein Occlusion, Where Future Holds. I request Dr. Harsha Bhattacharya to kindly come on stage. Yes, sir. Sorry. I think Dr. Harsha Bhattacharya needs no introduction. He's been the teacher of teachers. I have learned flax from someone who has learned ophthalmology from him. So, all over to you, sir.
Good morning to all. We are celebrating the Golden Jubilee of Nayandeep Netralaya. From my institution, I carry greetings and best wishes to them. So next 15 minutes, I will be talking on surgical treatment and anti-VEGF in retinal vein occlusion, where our future holds. Now see, it is a disease that has no treatment but has many treatment. In 2002, Sohan Singh Hare told. And let us see what is the present scenario. At this moment, there are 16 million people across the world are suffering from retinal vein occlusive disorder, and it is the second common retinal vascular disorder after the diabetic retinopathy, and according to the report, it is progressively rising. Now we know that various medical and surgical treatment have been described for retinal vein occlusion, the lifestyle modification, risk factor mitigation, and the treatment started with anticoagulants, and now presently many people are trying with antithrombotic treatment and they are claiming various success. Regarding the surgical treatment, the internal decompression like RON and surgical cannulation of the retinal vein with the TPA and the external decompression of the optic nerve schizotomy was also tried. Now recently the anti-VEGF agent has come into the ground of battle. Now regarding the origin of concept of retinal vein occlusion or treatment for the retinal vein occlusion, that is the RON. In 1978, a neurologist proposed the neurovascular compression at the optic nerve head is the cause of anterior ischemic optic neuropathy. Depending on that concept, 1988, they have performed the arteriovenous schizotomy for the branch vein occlusion. In 2001, the Oppermack suggested RON for central retinal vein occlusion. The hypothesis was there compartment syndrome or scleral outlet constriction or bottleneck syndrome. It was the motivation behind the RON, that used to think that there is a constriction in the optic nerve given by the lamina cribrosa, and with a BRB or knife, if you cut it, the stricture will go. But the fact is different. Here you can see in the lamina cribrosa level, the optic nerve head diameter is 1.5 millimeter and behind is 3 millimeter. The fact is that the myelination start retrolaminar part, not the prelaminar part. Moreover, the lamina cribrosa is a fibrous tissue. Cutting the fibrous tissue, it will not cause any relaxation. Second concept came the retinal vein occlusion. When the retinal vein occlusion occur, cannulation of the vein. It was tried in experimental level as well as human, along with the TPA. In the control group of animal, they have shown when the thrombosis occurs, histologically they have shown there is occlusion of the vein, and some time after the vein may be cannulated. The below picture you can see. In the experimental group, after cannulation and injection of TPA, they have demonstrated the veins open up. The second right hand side picture, the second picture. This procedure was tried in human with controversial outcome. The concept of surgical decompression for branched retinal vein was popular for some years. They used to cut the sheath at the arteriovenous crossing, but when the electron microscopy of the specimens were done in cadaveric eye, they have found that it does not follow the concept, there is no validity of the concept of sheathotomy, because vein abruptly change its direction at the AV crossing. There is focal stratification of the basement membrane. It is not at the touch of contact, it is in the opposite wall, and this stratification does not dissolve, and there is a focal narrowing of the vein. So sheathotomy unlikely to give any benefit. There are some histological studies on the natural course of the retinal vein occlusion. In the left hand side picture you can see the vein is occluded at the arteriovenous crossing side. In the other side picture, right hand side, your left hand side picture, you can see the sclerotic artery on the other picture, and the cannulated vein recanalization has occurred without any treatment. So increase of perfusion in some case following vascular decompression or cannulation may be simply due to the natural recannulation of thrombotic vein. In the era of anti-VEGF, 1970, the therapeutic implication of anti-angiogenesis was first recognized. 2004, anti-VEGF agent was first used in clinical ophthalmology. Since then, innovation of different anti-VEGF molecules, combination of agents and delivery methods guided by clinical trial have transformed ophthalmic practice as well as profoundly changed patient's perspective in retinal vein occlusion management. At present, anti-VEGF antibody is a standard of care. Now let us consider the pharmacological property of the anti-VEGF agent. Now we know the pharmacologically, if you want to evaluate a drug, the efficiency and effectiveness of anti-VEGF can only be determined by its pharmacokinetic and pharmacodynamic data. This data depends on the drug diffusion, availability of the specific protein in the host tissue, and binding capacity of the agent for drug retention in the biological field to deliver therapeutic concentration at the target site. The other variable determinants of drug action are VEGF level in the vitreous. You know the VEGF level in the vitreous is a variable. If any person suffering from obstructive lung disease, his VEGF level in the vitreous increases. Anybody taken statin or anti-cholesterol medicine, it rises. So many conditions are there. So VEGF level inside the vitreous is a completely individualized factor. The vitreous rheology changes along with person to person depending upon the eye condition, disease condition. The structural property of the drug in terms of charge, molecular weight and protein binding, all these factors determining the potency of the drug. Unfortunately, all this data on human is not available for anti-VEGF because of difficulty in getting vitreous sample. The present informations are based on animal experiment and findings for the human blood. We know that there is interspecies variability, and we know the different nature of the plasma protein in comparison to the vitreous protein. So this nullify the accuracy of data while translating the laboratory information for a human being. Importantly, a recent study has shown that in the body an anti-VEGF antibody also produced because of the barrier deprivation of the blood retinal barrier. At present, pharmacodynamic rank order of affinity and potency of an anti-VEGF drug is not clearly understandable. pending this data, medical science cannot say what the body does to the anti-VEGF drug and what the anti-VEGF drugs does to the body. The current measuring yardstick is visual acuity and OCT findings. OCT accuracy has been questioned by different authors, and the biomarkers for evaluating the drug are evolving. Now, intravitreal anti-VEGF drugs inhibit the functional activity of pro-angiogenic factor with different target selectivity, different affinity and potency in nanomolecular to picomolecular range. So fine. So accurate pharmacokinetics and pharmacodynamics informations are of paramount importance for determining its clinical use and outcome. Pharmacokinetic and pharmacodynamics of anti-VEGF drug is conditioned, and so dose of the anti-VEGF injection should be tailor-made. The same dose will not be working for all persons. As you know, when there is a vitrectomy, we have to give half dose. It is a proven fact. Now, how we regulate our practice? There are different RCT, different protocols. They guide the use of anti-VEGF agent. Now, what is the fact behind? The RCT has many limitations. It does not, RCTs are designed with an internal validity of the mind. The investigator find out what should be the result on a rarefied population which does not represent the world population in real life. Then we see the RCT, what are the condition of the patient? Your patient should include all the inclusion and exclusion criteria. The RCT provides protocol and solution. It is a one-size solution which may not fit to all patients with same disease. RCT said if protocol is not followed, the treatment has not been done. And surprisingly, two RCT we cannot compare because of the intervariability of the study design and study evaluation method. RCT says meaningful visual improvement without any quantification and definition. Most importantly, no post-authentication study report on any anti-VEGF drug is available. The RCTs are marketed, but we do not know what is the post-authentication result. So this is the reference. Now I have compiled some of the RCTs. You can study these RCTs and find the validity of my statement, and the reference is there. All detailed additional information are there in this reference. What we learned from the multicentric study? Multicentric study compared the treatment outcome of different drugs and different modalities of treatment, suggests some protocol, provides short-term result, never produce data and evidence on the duration of treatment. You will see that they make a statement, as the study is in progress, the data cannot be made public. This study do not define safe time to start the treatment for best outcome for the long-term basis. Now, what are the gaps in current understanding of anti-VEGF? Raise some important question in the pharmacological management of retinal vein occlusion. Number one, uncertainty with drug selection. Which drug should be first? How long this drug can be used safely? If first line treatment fails, what next? Which drug will give definite result? Fourthly, how to classify optimal response and define the poor or non-response phenotype of patients. Till today, there is no consensus on these vital issues. At least I could not find in the literature. Every report you will see encircling on a magical 15 letters, that too in ETDRS chart, and all of us know what are the limitations of ETDRS chart in real life. This chart is used only to define a minor difference between two records of vision. So pending all this information, the present wild and woolly world of anti-VEGF will persist, and that we are seeing in the real life. Now, the gold standard of a drug is determined by its comparison of the result with the natural course of the disease. Now let us see how the anti-VEGF and the natural course, what is the difference. You see a case of central vein occlusion without any treatment, it is healed up. You see the natural resolution of a branch vein occlusion, it was there, it is healed up. Now what the study said, 1/3 the systemic review and meta-analysis, this is the reference, 1/3 to 3/4 patient improves 15 letters by 18 months considering ischemic and non-ischemic disease. Another study said 70% of the major BRVO and 58% of the macular BRVO improves by 3 lines or more by a median period of 3 years observation. In our place, we see that 50 to 60% case maintain 20/40 or better vision even without any treatment. So, natural course studies are scanty, mostly retrospective, often extracted from mixed group of disorder, sometimes small study population or comparative with sham group of RCTs, resulting to a contradictory and confusing conclusion. So, natural course of BRVO should also be interpreted with caution. Now, conclusion and take home what I want to say. When several treatments are available for a disease, it indicates none of the treatment is effective or equally effective or none is superior to other. Concept of surgical treatment and anti-VEGF has begun. It will require further development which lies in the hand of the future researcher. Treatment versus no treatment, no much difference in long-term outcome. Now, one study said that however successful treatment, the result is often temporary. Following several intravitreal injection of anti-VEGF, some individuals have no impact on the resolution of macular edema, while others have poor visual prognosis despite full resolution of macular edema. I think all of us who are trying anti-VEGF, we have the same understanding in our patients. The radial optic neurotomy and scythotomy are analogous to vascular surgery. So, vascular surgery has potential and intervention in radiologist may take a great role in re-establishing retinal circulation in retinal vein occlusion as they do in case of cardiac ischemia. Now, understanding on molecular mechanism that we do not know in detail in retinal vein occlusion, the cellular signaling in response to occlusion, why the cellular signaling occurs in the eye, it is not associated, not known, and the molecular mediators which exactly give rise to this cascade of events is not known. If it is known, then it will give a precision and targeted treatment for the condition. Till the invention of exact treatment, as we have learned from the yesterday's ROP lecture, the long-term benefit of retinal laser needs to be re-established, particularly to prevent binding complication of RVO. And intravitreal anti-VEGF will be to continue to remain as an adjunct medication. Now, the benefit of the anti-VEGF, diabetic macular edema, you inject when the macular edema resolve, do focal laser, they will get long benefit. Proliferative diabetic retinopathy, you inject, then within 7 days you do PRP, there will be no choroidals and nothing. So this is the practice we do because our patients are coming from the far-flung areas. So we give an anti-VEGF, at least in my practice, and then put anti-VEGF. One sitting PRP is okay because they cannot afford to come several times for doing the PRP. So these are two definite advantage of anti-VEGF is there. You can shorten the duration of treatment intervention by drying the macular edema, and also you can do complete PRP in case of ischemic CRVO to prevent neovascular glaucoma and other things. These are two examples I am showing. Now, the time of awareness has come. There is a BBC report, the doctors selling bogus treatment to people facing blindness, and more than 2 million people worldwide have retinitis pigmentosa, but for most of them there is no treatment, and the stem cell treatment is a popular, and surprisingly the stem cell treatment or stem cell is not registered under drug, so they are not liable to answer, they are not answerable in the court of law. Now you see the history may repeat. This is the famous picture of Nuremberg trials. So if you are not doing a ethical practice for retinal vein or retinal vascular disease management, sometime we may have to undergo this trial. So what I believe, no research can be great, even staying true to self, where humanity is compromised and wisdom ignored. So thank you for the patience hearing.
Thank you so much, sir, for a beautifully elaborated insight into retinal venous occlusions. Sir, if I may ask, as you know, in a practical day-to-day life, anti-VEGF has been the primary therapy. Is there any role of steroids in such cases? And if you consider, when would you consider? At what stage in the pathology?
The steroid has, as my talk is on anti-VEGF agent, so I did not include the steroid. Now the steroid has a role, but the result of the steroid is more like the same. Some group of cases who are naturally to be healing, they will respond, and who will naturally not relieve, they will relapse the edema. So this is my personal experience.
Okay. And when would you add the laser on? And would you do angiography before it, sir?
Yes, angiography is a good marker, but the thing is that how many cases will become ischemic, it cannot be predicted. But if you angiographically you find that a sufficient area
Yes.
is ischemic, capillary dropout is occur, then better to do a laser photocoagulation instead of waiting to neovascularization develop. Because our nature of our patients are very much unpredictable. They will come with a neovascular.
Can't predict whether they'll come for regular follow-ups. Right.
Only disadvantage is that the superior, if you do laser, they find difficulty in walking.
Yes.
And if the PRP do if visual field is
Visual
restricted.
field.
But it is a destructive procedure. Laser is a destructive procedure, but to retain vision
Central
ambulatory,
vision.
this is more important.
Yes. Thank you so much, sir. Any further questions from the audience?
I would invite Dr. B.A. Shah, sir, chairperson for this session, to join, and Dr. Prashant Bavankule to go with his speech.
Thank you. Thank you.
He's going.
Okay. Shall I? Yeah. Okay. Thank you.
Management of Irish Trauma.
Yeah. Thank
Dr.
you.
Prashant
Thank
Bavankule.
you. So at the outset, let me thank Shalabh and Pallavi for this wonderful opportunity to be here to celebrate the 50th Golden Jubilee of Nayandeep Netralaya. It's more than a friendship, and it has been almost, look at the planning which is necessary for any success in your life. 1.5 years back, Shalabh told me कि प्रशांत आपको आना है, and then I forgot. 1.5 years back, and the way he has planned it and now it has unfolded into such a grand ceremony speaks about the type of planning which has gone, the efforts which have been taken by both the couple, and I congratulate them for all the wonderful show they have put forth, and I wish Nayandeep Netralaya to grow leaps and bounds, and I would like again to come back at 55th. I know for sure 75 is too long for me to wait for that long, but 55th I will be here to see the growth of it. First step will be 55, sir, I will get more lychees. So that is the way. So with this small words, now let me come to my topic. Friends, I would be speaking on a slightly untreaded path, that is going to be the management of iris trauma. We are all phacosurgeons, some of us are retina surgeons. We do wonderful phacosurgery, we do wonderful retinal surgery, but this is the tissue which is usually forgotten, and that's why I have labeled this presentation as a forgotten. The iris abnormalities usually are not taken care, and that's why, and why do we not take? whenever you have a trauma, be it a iatrogenic or a surgical trauma, iatrogenic or a trauma in the setting, you upsize. Why? Because of the fear, misplaced fear of infection and sympathetic ophthalmia, and that is the reason why many a times, in spite of doing wonderful anterior posterior segment surgeries, you have such distorted pupils, which causes a lot of problem to the patient. So what are the indications? Basically, any patient who does not have a good iris pupillary diaphragm ends up having a glare, visual disturbances, photophobia, and most importantly the loss of cosmesis, which is equally important because the beauty of the face lies in the eyes and the beauty of eyes lies in the iris pupillary diaphragm. Without it, the eye becomes crippled, and these injuries which happen at a young age can definitely have a social impact on their growth. So this is a video bouquet of some of the cases which we have done in our institute, just to share with you and to get you interested in this management particularly. So this is a patient who had undergone cataract surgery elsewhere, and he was referred to us for scleral fixation. He had a surgical aphakia. You can hardly see any iris tissue, and this is the amount of iris tissue which was seen. Of course, we wanted to do scleral fixation, but we also wanted to create an iris pupillary diaphragm for this young patient. So this particular video will begin after I have done the scleral fixation. So first thing after having done the scleral fixation is that with the help of a iris retinal forceps, I am trying to unroll the retroflexed iris, which was 360-degree retroflexed for a pretty long period of time, and to my surprise it was all 360 degrees retroflexed. So under viscoelastic, after deepening antechamber, I am trying to assess how much is the iris tissue and what type of a strategy I am going to do. And I realize, well, I can do away with simple 4-throw knot pupilloplasty. So through a side port at 7 o'clock, a tenoprolene needle goes through, then it engages the iris at 5 o'clock meridian, and then it will come out through the port at 5 o'clock. This is a classic 4-throw knot pupilloplasty which is popularized by our own Dr. Amar Agrawal sir. And here you see that the iris tissue is approximated in the inferior quadrant. The whole overall pupillary aperture is coming down, and this is what classic 4-throw is done, and you can see the approximation. Same procedure is now repeated at superior, that is 10 and 2 o'clock meridian, and once you do it, you have reduced the size of the pupil. This is the pre-op photograph, and this is the post-op photograph where the patient had a decent enough pupillary diaphragm. Now this is case number 2. This is a case of a traumatic cataract in a young child with a 180 degrees iris root disinsertion. Well, of course I had to do a emulsification, but most important thing is when you are doing a cataract surgery in this particular case is to preserve this iris tissue which is available to you at this point. And how do you preserve? Is to keep it away from the active ports of suction, and that is why initially before I do a cataract surgery, I have done is I have used an iris hook you can see I have used an iris hook to get it out of the active port, and then the video again starts after having done a phacoemulsification and lens placement. Now I realized this is the iris tissue 180 degrees disinserted. I create a scleral tunnel here about 2 mm from the limbus at 9 o'clock, and it decide to anchor. So tenoprolene suture goes through the iris root at 9 o'clock meridian through the scleral tunnel, and these sutures have to be buried, otherwise it can lead to suture tract infection and irritation to the patient. So once I have anchored the iris root at 9 o'clock meridian, I look at that the pupil is beaked or pulled towards the 9 o'clock meridian, which I am not still happy with. So I decide to do an additional 4-throw knot pupilloplasty, which was elaborately shown in the first video, and this is what I am doing. I do a 4-throw knot pupilloplasty. So this is the case after having done 4-throw knot pupilloplasty. This is the pre-op photograph of the patient, and this is the post-op photograph of a patient where you can see near circular pupillary diaphragm and a nice pupil, circular pupil. Now another case, this is a case which had undergone a wound repair, corneal tear repair elsewhere. He had a cataract. This is the iris tissue which was available. There was a lot of iris tissue which was not available, was upsized. So here was a different type of a challenge here. So here again the video will begin after I have completed the cataract procedure. After having put the lens, I am trying to assess how much is the iris tissue which is available to me and how am I going to manage with it. So first when I unroll this, I realize this iris tissue is available up to 7 o'clock meridian. So first my job is to anchor this available iris tissue to the sclera at the iris root at 7 o'clock meridian, and that is what precisely I do. I create a scleral tunnel there, and then a tenoprolene suture goes as shown in the second video, and it is anchored at 7 o'clock meridian. Now this is a big iridodialysis cleft left over here, so I decide to complete that one more suture. I decide to place it over there. So here goes one more suture, and I have completed. So now the challenge is here, you can look at this, up to this are 4 clock hours which does not have iris tissue. So how do I compensate for it? I decide to do approximate the iris tissue from 10 o'clock to 5 o'clock meridian, and that's what precisely I do. I do a 4th row knot pupilloplasty, and once I do a 4th row knot pupilloplasty, this is what the 4th row knot pupilloplasty is done, and so there is a big gap here, devoid of tissue. So additionally one more suturing I do, that is once more I anchor that iris tissue as if I am doing a iris anchoring, root anchoring, and once I do this with a tenoprolene suture, this is the end result of this particular patient. So I have not just done a IOL rehabilitation, but you can see a near normal pupillary diaphragm, iris pupillary diaphragm I could construct, and therefore give him a better quality of a vision. Now this is case number 4. This is a case which had a traumatic subluxation of a cataract with loss of iris tissue was our initial assessment, and we could see that here there was a, I thought this is a closed funnel or a vitreous hemorrhage with a early creating a detachment like picture. So my plan of action was of course to do a posterior segment surgery, but whenever we do posterior segment surgery I have to use a tamponade. If I have to use a tamponade in the form of an IOL silicone oil or a gas, it usually causes secondary glaucoma or corneal decompensation because of the anterior migration in the absence of iris pupillary diaphragm, and that is the reason why we need to create an iris pupillary diaphragm. Otherwise we have to take a suture, which really does not work as normal as we can do in a case with the available iris. So here the video goes, I am doing lensectomy. I am cutting off the vitreous wound which was incarcerated into the wound and isolating the nucleus via lens which was all stuck up in the vitreous, and after doing this I complete the vitrectomy and then do a fragmatome, use a fragmatome to do complete a lensectomy. Luckily for me it was total vitreous hemorrhage, retina was on. I complete the endolaser barrage 360 degree. Here this I am doing is a base excision to see whether there are any breaks in the periphery, and after having done that I realized that there is a iris diaphragm, pupillary diaphragm which I need to construct. So now I will initiate the video from here. So now I am assessing how much is the iris tissue. Luckily it was 270 degrees of iris root disinsertion. So my job in this particular case was relatively easy. I had to anchor this iris roots at 3 meridians, say 2 to 2 clock hours ahead. So first job I do it at 2:30 o'clock. The iris root anchoring is done, and the same procedure is then repeated at 1:30 and 5 o'clock, and this is what the end result is. So I have not only done the posterior segment surgery, I have done a lensectomy, vitrectomy with scleral fixation of IOL, with a tamponade, with an iris root, iris pupillary diaphragm reconstruction for this young child. Now this is case number 5. This is before repair. In fact, this patient had undergone, we did a repair, and this was pre-repair and this was post-repair. And this is the picture again. You can see the iris root disinserted much. So I preserved, instead of excising the iris tissue which was dangling while doing a primary repair, I preserved it, and at a later stage, about 2 weeks later, this is what we do. We do a complete vitrectomy and then do a laser, and again I do a reconstruction. This is a more challenging case. Here the iris root was disinserted more, the iris tissue was all distorted. We could not really make out the anatomy of a long standing iris root. Again I anchor it at 2 or 3 places, and this is the end result post of day 5 after the repair. Well, this is a case which I would just like to share with you. This is a case of a congenital aniridia, and this not congenital, this is a case of a pediatric cataract. Even at the best of the hands, when you are sometimes go lenient, this is what happens. So look at this. I do a complete phacoemulsification. Phacoaspiration was all that was needed for this particular young child, and while I am injecting this particular 3-piece lens, you can see what I have caused a damage. I have caused not only disinsertion but the tear of the whole iris diaphragm. This happens when you become a slightly relaxed, and it really gave me a bit, I was really very shaken back, means in a small child, 2 years kid this was. So I wanted to correct the guilt which I had created iatrogenically. And this is what I did is, I did a repair for this particular child. I will show you, and I could overcome the guilt to some better extent by doing a complete iris. I did an iris anchoring as well as 4th row knot pupilloplasty, and this is the post-operative photograph. So you can create such problems, but you can definitely repair. This is another case of a last case I am showing with you. This is a case of an aniridia. In an aniridia IOL, you are supposed to do an ANAV. The commonest reason, second commonest reason of poor vision in a case of aniridia is foveal first cause is foveal hypoplasia. Second is the photophobia. These are two common reasons why a patient with aniridia has poorer vision. Hypoplasia you can't help, but you can definitely put an aniridia IOL and cut down the light which is going into the posterior segment on the retina. So you use an aniridia IOL. Well, aniridia IOL, typically you have to dangle it with the help of two scleral fixated 6-proline or 8-proline suture. But that causes a tremulousness, and this suture disintegrates in the younger child over a period of time. So what we do differently is, we externalize and we do a glue technique for this single piece rigid IOLs, aniridia IOLs. Rigid IOLs come as a single piece. They are having an optic size of 10 millimeter. As you can see, after having completed a phaco, I am trying to put it, and I have created a scleral tunnels here, and I externalize this rigid haptics of this particular. This is the externalization of the rigid haptic. It is very fragile. You have to be very careful. After externalizing, you have to bury it into the scleral tunnel as we do in a case of a glued IOL, and this is the pre-op result and the post-op result of this particular patient. So this is a gluing technique for a scleral fixation of a aniridia IOL that gives more steadiness, more stability to this particular aniridia IOLs. So what we learn is, we need to repair whenever there is an iris trauma, be it an iatrogenic or a on-field trauma it happens. That helps you, the patient, by compartmentalization, especially when you are dealing with the posterior segment cases. You create an iris supported tissue for iris supported IOL. Importantly, you help the patient with a cosmesis, besides giving him a better quality of vision because of less glare, visual disturbances and photophobia. So friends, patients do come to you for a lens, getting a lens. He comes to you for a retinal surgery, but as a surgeon, you need to give him more than what he asks for. And an iris tissue repair is a place where you should invest your time for those poor young patients. Thank you.
Prashant sir, first of all, a huge applause for those brave and skillful surgeries. They were just awesome. How they looked pre and post-op. It's beautiful. But if I may ask a question, you have repaired iris which were quite old, as I see. So any old iris which is dangling or which is detached, so you can attempt that with this.
Of course.
And there is no major complication of bleeding or anything. Have you ever faced? I'm sure you're very skillful, but still.
No, we will go by step. It is preferable to repair and fresh vital iris tissue. The repair of that is relatively easy because the iris tissue is more elastic. It does not give away other places. You might have seen in the very first case, that case was done about 3 months later to me. So the iris itself was very friable. So wherever you put a suture, it tends to give away. Or when you are trying to pull, you induce more iridodialysis. So that is a challenge. But remember, what is the other substitute to it? You have to use an iris implants, which can get displaced. They are artificial tissues. So if you are having your own tissues which are biocompatible better than any iris segments or whatever we use, definitely it is going to. Though if it is devitalized, it acts as a barrier. It creates a diaphragm. That is the importance. And so you should always, that's what, in a segment, whenever you have a primary trauma, reimpose that. The message what I want people to is, do not abscise, leave it, push it inside and leave it for the second step. You can do. Or in a case, in a pediatric cataract where I induced a dialysis as well as pupillary rupture, iris rupture, I could do it on spot and you could see the result. It was almost normal pupil. It reduced my guilt. So it is worth investing into it.
Yes, it was. And one more, what dilator drops would you use after you do these surgeries to dilate and see the peripheral retina? Because many of them had retinal issues.
See, I have not gone for pinhole pupilloplasty in all these cases. I leave about 3 to 3.54 millimeter pupil, and once the iris becomes atrophic, you don't even need a dilator. Most of the times, most of the retina surgeons can see through 2 to 3 millimeter. So I can see any patients with 3 millimeter pupil. Huh?
Thank you.
Thank you for nice presentation on this very common entity which we see often in our clinical practice. We have one or two questions. In iris trauma, it is often associated with hyphema. In that case, should I go for some days for medical treatment and should I proceed for the surgical treatment if I find some iridodialysis with hyphema? So what's your opinion?
Yeah, we are in two settings. One is, are we having a open globe injury associated, or it's a closed globe injury? In open globe injury, naturally I have to close the globe, preserve the iris tissue, reposit it back, antechamber, try to wash it if possible, or if the blood is incessant, you can push an air bubble or a viscoelastic and leave it there, and then do it as a second procedure. In a closed globe injury, again, let the inflammation die down. So the ideal window would be about 10 to 12, 14 days later. Once the inflammation dies down, then the hemorrhage, whichever is there, if it is not causing corneal staining, it is an ideal window to go that time and repair, and that is the best time to repair. You will have a fantastic elastic vital iris tissue to repair.
So what is our common observation that the mydriasis persist for longer time and photophobia does not improve what we expect from this type of repair. So what's
Sir, we need to understand, I am not saying we are making it perfect, we are making it near normal. So a pupil which is 10 to 12 millimeter versus a pupil which is 4 to 5 millimeter is an acceptable compromise in such situation.
Thank you.
Thank you, sir.
I think we'll be over to Pallavi. We'll go for the life surgeries. Life surgeries? Yeah.
I'll just invite Dr. Pramod Binde for the felicitation of our chairperson, Dr. B.S. Jha. So now the deferred life surgery will start. By the time, if anybody hasn't taken the breakfast, please take the breakfast. गरम निकलवाए. सर ले लीजिए नाश्ता आप लोग. सुधांशु नाश्ता लिए. गरम ले रहा है. निकल रहा है. जिन लोगों ने नाश्ता नहीं लिया है, चाय बाहर है, नाश्ता है, लेकर यहाँ आराम से आ जाएं, कोई इशू नहीं है, यहाँ भी खा सकते हैं.
Abhishek, to please come and chair the session along with Dr. B.S. Jha. Sir is coming, having breakfast.
Good morning, gentlemen. I would love to invite Dr. Love Kochkave from Kolkata.
Good morning, and thank you so much, Dr. Salab, Dr. Pallavi, for inviting me for their Golden Jubilee celebration. This is a deferred life surgery which I so I think the orientation here is different. I am sitting temporal, so this is a 90-degree incision, side port, and this was almost an around NS2 grade nucleus in which and about 13 minutes sir. तो आगे बढ़ा के सर. हाँ ठीक. This I will And here you see we are initiating the capsulorhexis. I am a left-handed surgeon, so you will not understand what is happening because most of you are used to right-hand surgery, and here the orientation also is different of the video. We will be doing a temporal incision, so after the rhexis you will understand my sitting position. So rhexis normally I do with a trypan blue. In this case it was done without staining, and now the rhexis gets completed. Initially we give a 2.2 millimeter incision. Then the hydro procedures are done, and what is important after hydro procedures, what we all should do in a cataract surgery is rotation of the nucleus, because again that will help the equatorial fibers to loosen up, and later on in post surgery the chances of posterior capsular opacification will be much less. So the nucleus is rotated, and then I think part of it the sleeve was not proper, so I had to come out again and then put the sleeve properly and then start the phacoemulsification. And this machine is the first time I am using. We are more used to Centurion machine, but I must say that this was a very good well controlled surgery in the Stellaris Bausch & Lomb machine. What I am trying is a direct chop, and what you see is after the initial engagement of the nucleus, first crack is made, then we attempt a second crack, and the third crack, fourth crack, and at this point you get the first chop, first nuclear piece of the nucleus out. Change to segment removal, though in this case the setting was same for the chopping and the segment removal. The segment removal is done, first segment is removed, the second segment, the third, and once the segment removal is done, what I do is that I use a bimanual irrigation aspiration for the cortical, and it is up to the choice of the surgeon. You can use either a coaxial or a bimanual, whatever you are more comfortable with. Care to be taken that the aspiration port is always facing upwards, so that the posterior capsule is not does not get engaged in the port. And once the is done, then what I do is I polish the posterior capsule using hydro cannula. Normally I don't use cap back, you are just polishing with a hydro cannula. That works quite well for the posterior capsule. And then finally, this was acryol hydrophobic lens, and the lens was implanted in the bag. And the final viscoelastic removal and hydro procedures were done. That's the end of the surgery. Thank you.
Wonderful surgery, Dr. Love. Is this your first experience with flared tip?
I've done earlier. I think one more company is there which makes, I'm just forgetting that German company. Oatly. Oatly has similar tips. So I've operated on Oatly, not on this machine. Thank you. Thank you so much.
Thank you, Dr. Love, for the wonderful video. And I would like to invite our chairpersons from Patna, Dr. Pranav Ranjan and Dr. Subhash Prasad on the dais. Manna, एक chair. नहीं, अभिषेक, you please sit. सर करके गए थे अपना काम, उनको फिर अब जल्दी से बुला लिए थे. सर का फर्स्ट सेशन में था. So we have Dr. Pranav Ranjan, IZOC President, Eastern Zonal Ophthalmic Congress, with us, and Dr. Subhash Prasad, the renowned cataract surgeon of Bihar, with us. And it's like they took the pain to coming from all the way from Patna. I'm very thankful, and we are privileged that they are here with us. As Dr. Partha Vishwas is busy in operation theatre probably, so I'll call Dr. Pramod Binde again with his topic, Retina, Yesterday, Today and Tomorrow.
स्लिप नहीं होगा ना. So, good morning everybody. Once again, congratulations to Salab and Pallavi for this grand celebration, and thank you for good hospitality. So, a subtle change I made in a title, basically, but we will cover what we wanted, and probably this is a potpourri of a few innovations quickly running through, just to cover up. So, last decades or so, innovation that changed the practice of retina. That's what basically what we wanted to go through quickly. So there are a lot of things are there. I'm just highlighting few. Anti-VEGFs, biosimilars, imaging technology, gene, AI obviously is coming up, treatment for geographic atrophy, and few innovations in the surgical part. So basically VEGF increases the permeability of existing blood vessels, and sometimes it can lead to new abnormal retinal blood vessels and capillaries, and that's something common condition we face, like AMD, diabetic retinopathy, macular edema, vascular occlusion and ROP. And anti-VEGF drugs block this activity of VEGF in the eye, and that's a boon to us now. This is just small short journey, like first time we have a research discovered something like in 89, they named something like a VEGF, and as time passes we realize that elevated VEGF levels 1994 and 96, researchers showed that if you inject the VEGF in animal eye, it can lead to growth of the new blood vessels. First phase trial for cancer in anti-VEGF started in 97, and when it comes to ophthalmology, the first treatment for VEGF, that was pegaptomib, Macugen, it was introduced in 2004, and then there is a crop. You have ranibizumab coming in 2006, of aflibercept in 11. In between 2015, Intas came with their first biosimilar Razumab in India, which subsequently actually it was in a 10th biosimilar, but on ophthalmology it was first, and way later on to 2021 actually in US FDA approved the another one biosimilar by Samsung. So brolucizumab in 19, and recently we have latest kit is 2022. We have faricimab, which routinely being used now. Trials are over and it's open for all the treatment. In between, people are working on a sustained delivery system. The current role for anti-VEGF in retinal disease, which includes macular edema of various types, CME, choroidal neovascular membrane due to any etiology, proliferative retinopathy, ROP, and neovascular glaucomas. What people are working on now, because we need every month injection, but basically is sometimes lot of practical issues. So long durability are looking for. Newer drug delivery system, something like a sustained implant, which even sometimes can last for 6 months, and refillable implants also people are working on. Now there is a such difference between biosimilars and biobetters. So biosimilar basically they are equally effective, but potential to reduce the cost and increase the treatment adherence. That's why, because compliance will be better, cost is less. As against biobetter, these are biologics that are considered to be better than the original molecule in some aspects, and they are basically a little bit modified chemical and have a different amino acid sequences, and that way they are probably helps better. Coming to OCT, again OCT has changed a lot. There is a long journey. First OCT is introduced, like a first generation commercial OCT was available in 1996. Then we have coming into 2000 second generation. We have Stratus OCT came in 2002, and spectral domain came in 2006. What we have now is commercially available, basically swept source OCT, and the latest is what having is OCT angiography. We will come to that little bit. So basically, OCT is a non-invasive diagnostic technique. Works on a principle of low coherence to interferometry. An image is created by, as you see the image here, is as good as histological section it is giving, and so which was never possible when you are a living person. You are getting a histological section practically for all ocular retina. There are different technologies, as I said, time domain, spectral domain, and now the most important is swept source OCT. This is like a time domain, and you have a spectral. You have see the resolution changes, and when it came, so not only resolution, the depth what we have. So spectral domain, it gives you as a little bit vitreous and maybe up to early inner layer of choroid. When you come to enhanced depth OCT, we go further deep, and then when it comes to swept source, right up to sclera, to vitreous cavity, you cover. And not only that, now with time you are getting 3 millimeter, then 6 millimeter, almost we have 15 millimeter long scan, so large area, entire macula you can cover this. Then came another imaging, which based on ability of to image the flow of in the retinal blood vessels, and what we called as OCT, AR OCT angiography. So that practically eliminates the need for dye, so it become a non-invasive technique, and also because of limited obstruction because of leakage. So what it gives you a beautiful picture as is network that you seeing here in a neovascular, choroidal neovascularization. This is a swept source, and you are having a comparative en-face view. This is another case showing just PED here, and 3 weeks later patient came for review. You have heme around, and this network you are seeing, and treatment of response when you started between 3 injection, and what you see is regression there. So you can now not only diagnose, you can follow this case entire course of the disease. This, and just to show compare, this is FFA, this is your ICG angiography, and you have here SSOCT-A giving wonderful picture, all the blood vessel, each vessel you can so well delineate, much better than even some, in a few cases. Of course there are limitations in both, I am not going into detail, but this is a good way, sorry. So coming to further advances, now we have intraoperative OCTs. Basically it's a microscope mounted OCT. So basically it's helpful mainly in a interface, vitreoretinal interface conditions what you are dealing with. So also it's important now because a lot of gene therapy being coming up, So you need to know exactly where you are injecting. So subretinal drug delivery system to have a precise location intra-op OCT is very, very useful. And with newer technology, we'll come to that little bit, is integrated with 3D heads of visual display. So things have become much more evident now. There are other innovations still going on. Hydra OCT, these are dual wavelength being used. Sparse OCT is a portable system. Speckle denoiser, so that you enhance the quality, and combination of virtual reality with a OCT machine, these are in the pipeline. This coming to fundus images, again here sea change, and this is one picture probably sums up everything what we started with a 90D slit lamp to direct ophthalmoscope, indirect ophthalmoscope. So what you are seeing is a Merenta image, 163 degree whole picture. So that is the way we can image now, and that too with a small pupil. Really do not have to. And this is long journey, impressive history, looking started from 1851 to 2000, things are again improving further. So basically fundus camera, basic optic design based on the principle of monoocular indirect ophthalmoscope, and there are different modes of imaging. Typical camera gives you around 30 to 50 degrees of image, and if you with a montage little bit change, what you get is somewhere around multiple picture clubbed together, what you call some other area can cover maybe around 60 to 70 degrees, but with a wide angle which is gives around little bit more than 50 degree, and what we call as ultra wide field imaging, which give even up to 200 degree of imaging fundus coverage now. So it has enhanced resolutions, shorter imaging process time, faster acquisition, and other because of digital imaging, the acquisition and telemedicine usage, it adds on. So what is important here is, it's useful, you can use in a small pupil eyes, and also patient those are non-compliant, particularly pediatric age group, and where I deal a lot of ROP babies, where you just cannot even examine the fundus in OPD, but you can get an excellent picture even with Optos or Cirrus. So we have contact, non-contact options available here. RETCAM and Forus we are using for these ROP babies and retinoblastoma patient routinely, but OPD you are using something like this is a typical camera what you get, and this is Clarius with the 4 pictures together, it goes almost 260 degree. This is Mirante up to 160 degrees, and RETCAM, Optos is giving around 200 degrees, and what the circle drawn inside, this was a typically used to be 7 field fundus photograph. When diabetic retinopathy study DRS was done, it was 7 field. That was, look at it now compared to this area which has covered, and lot of now we realize lesions are beyond this area which we used to very easily miss, which we are covering. This is what you see, 7 field which you miss, peripheral, all this area which you cover in a like a wide angle system, and also you can assess your completion of your pan-retinal laser photocoagulation, that obviously minimize the risk of recurrences. And this is what I was talking about, ROP, which obviously difficult to examine, follow them up. So this is a picture on a RETCAM, and Optos gives you as good as, so lot of patient what we used to examination under anesthesia, we do not need to, we get Optos done, we will see picture, if it is good enough, do not have to subject baby to a general anesthesia examination, and this is everything through small pupil. So excellent view that gives. And again multimodal imaging, I am not going to go to this, and future obviously is integrating this fundus photography, angiography, OCT together. We are having quantitative autofluorescence now, minimum handling, so wide field cameras which are having smartphone cameras. We are going ahead with a now lot of portable technology, and telescreening is feasible now only because of this portable devices. Coming to gene therapy, basically gene modification, what we do is either replace a mutated gene, add a missing gene, or modify an existing one. Most of these eyes we use adeno-associated viruses, what we call as AAV, because they have unique biology, simple structure, and poor immunological response, so they are relatively safe. So why there is an increase in interest of ophthalmic gene therapy, which we call is easy accessibility for treatment of the eye, has an immune privilege status, so I can accommodate the angiogenicity of the viral vector, and because it's a tight blood ocular barrier, so it prevents other organ from getting affected or contaminated most of the time. So first GMON project was started almost 20 years back, and with a better understanding, and we are hoping to find a few newer treatments for various formats for hereditary disorders. The common targets are now Stargardt's retinitis pigmentosa and of course lesser congenital amaurosis. And other treatments trials are in pipeline, particularly for wet and dry AMD and diabetic retinopathy. Luxturna was the first approved gene therapy in December 2017. And basically what you need here is biallelic RP65 mutation has to be conferred, because this drug acts only on that specific gene, and that's why you cannot have it will not affect, it will not have an impact on any other one. The subretinal injection is given, and this RP65 gene is liberated there, so it enables retinal cell to produce missing enzyme. So probably what you do is it prolongs the disease course and probably try to maintain existing vision, but you need to have functional cells there. If PLPR vision, obviously these eyes will not help in this scenario. And most important, we need to counsel patient that it does not restore the normal vision. So Stargardt disease, we have multiple trials going on, what is called the Starlight trials, phase 2, 6 patients showing some promising result. Their Dragon trial is a phase 3, again showing some response. For retinitis pigmentosa, you have Restore trial and some targeting PBG65, CT, PDG6BB. There are a lot of multiple trials going on. We have to await their response. Okay, but again, this is photo switch. Basically, ganglion cell, we are targeting them to stimulate response to light sensitive cells. Though it's not exactly gene therapy, but it can be in a combination of gene therapy, may give in future some have benefit. Now, what are the challenges in gene therapy are? Treatment is very, very specific to gene, as I said. So one must identify genetic defect, and gene should be targeted to that specific defect alone. So it has its own limitation as far as broad population impact is concerned, and obviously it comes with a very, very high cost, just beyond anybody's capacity. And of course, we need to devise scalable manufacturing solutions and delivery methods of these gene therapies, and of course much more to come. But their results are promising. The word about gene therapy, till now we used to think it is not treatable, but recently 2 drugs are approved, like Pexatecoplane or Cyphervis, having a phase 3 trial, and other one is Avastina Captad. Basically, we just looking at the result, but at least earlier reports are promising, but wait is there, still long. Coming to little bit surgical part, first multifunction vitrectomy probe was given by Mackimmer way back in 1970s, early 19th century 70s, and then lot of modifications. So bimanual technique, split function probe was O'Malley and Hennis, they brought it, and then subsequently over last 30 period, conventional vitrectomy become 40 years almost was the standard of care. However, till we have started having a MIVS started somewhere in early 20s, like 2002, 2003, and they have microcannulas. They are initially non-wall and now wall, and along with comes with infusion cannula, and we have now available shorter and longer instruments as well. So advantages, if you see a transconjunctival, this is the eye 1 week post-op, so no significant change in a surgical technique, but when you look at these eyes, leaves the eye almost anything normal. Sometimes we have a difficulty in identifying whether patient had a surgery or not at all. So yes, cut rate is increasing further day by day, and why you need faster cut rate? Because it reduces the pull on collagen fibers. You see these 2 pictures, the vibration what you have here is hardly see any turbulence in a second case, and of course it prevents the outflow occlusion, so allows vitreous shaving without having a retinal much damage, and iatrogenic complications significantly reduced. Now cut rays, when we started our fellowship it was around 400 to 600, now what we are having a 20,000 cut available in the market, and vitreous hypersonic cuts are supposed to be coming in. You have a bevel probe now, so that reduces the distance between the retina approaches. And so what you see here is almost you can do steam rolling and cut through membrane as like you are a lawnmower technique, and you hardly need any scissors and forceps nowadays when you deal with these eyes. So of course this is come with a visualization system, need a different light sources. Previously we used to use this lander lens followed by irrigating contact lens. This is a surgery showing a sieving on landers, so hardly 20-30 degree views. Posterior pole used to see well, but hardly any peripheral view. We try to use prism, but as time passes, what we have now, this is again Swinon lenses, limited view, and this is a GRT. We could operate that. Dr. Bakulesh and Dr. Harsha will know, used to struggle so much with these lenses. We managed, but those time, because there was no other choices. But as time passes, what we are seeing is change in a technique and technology in what we have a lens. So we have this type of pupil, and what you see here now, keep on looking. So this is the view, what you see, which was never we could dream to have this type of view, and things are life is much easier for us with. So we have and not only that better view, it has excellent depth, so ease of operation, and it overall helping to reduce the surgical time. So of course, wide angle system, we have non-contact system and contact system as well. Now this is the one, see the same eye, just for a comparison I took. This is the view with the lander system, and the other one, what you are seeing is with a biome. So you can feel the difference here, and the way you get the view here. The last one, we have a 3D heads-up system coming up now. So we have a Carl's Eye system and Alcor system right now in the market. So this heads-up display basically come idea from aircraft flight decks, allowing pilots to view data on a heads-up position on their visors. So now surgeons can perform this procedure not really looking through IPSS microscope, but you can look straight in front of your monitor ahead and finish the surgeries. Of course, you need to use 3D glasses as well. So first system came in 2008, True Vision 3D system, and then Ingenuity came in the market in 2016 and followed by Alcon system. So this is a typical view you see in OT. The surgeon is not looking through microscopes, so looking straight ahead of the screen. So posture probably is better, and it has excellent stereo acuity. Also need a lower illumination, so it reduces the risk of phototoxicity, and depth of field also is much better than what used to be. But supposed to be having a better ergonomics, but that, and it has its own issues. And what you have here is integrated interoperative OCT and digital image overlay. What you can see, even OCT image can be relayed on your fundus screen, so you can exactly know where you are working, and even you get that depth perception. So head up system, and there is something called as head mounted display. This is another system, particularly Israeli group has come to start with. So there are two systems coming into the market. So now this system again is a fighter pilots they used to use. So visor in front of your eyes, and everything see on your screen. So you do not have to look at the straight, but you can move your head either way. You can have higher magnification, and you so have benefits of close-ups, immersive visual field, something like a virtual reality, and these are a dream as if you are playing on a like a 3D games, and that's the way surgeries are being done. And the last word is sort of artificial intelligence. They are emerging field. Basically, it helps processing a large data for a logical and meaningful interpretation with the image-guided treatments. It helps to detect a morphological fingerspace, and that's why it can predict the disease course, and also potential to improve screening coverage to resource concern settings. So basically, expectation of automation of the treatment in the future can happen when you have AI, but this has its limitations right now. But when you integrate this AI algorithm in clinical practice, probably it will take care of other things and will give more time for doctor-patient interaction and co-development of personalized management plan. However, there are challenges. It needs to large, more diverse and representative data set that fully represents real life. Basically what happens here, what you feed comes out. So unless the information is fed correctly and huge amount of information, then only system can analyze data and gives you corrected answer. So otherwise, if feeding is not proper, obviously answers are going to be something really disastrous. So we still have to go a lot of things to that. So all these recent pharmacological and technical innovations have revolutionized the management of retinal diseases. It helps to achieve proper diagnosis and plan, appropriate management also, and thereby helping to improve the efficacy and reduce the side effects. But yes, right now, there is still few unanswered questions are there, and it comes with a huge cost, and that's why it has a limited accessibility and will take some time to have a widespread adaptation. Thank you very much for patience hearing. Thank you once again. I know I have run through quickly so many things, but
no, thank you, sir. So there is nice update and exhaustive, but very informative information about what's going in the vitreoretina nowadays. Sir, just wanted to know about the prospect of gene therapy. In how many years we can promise something for the patients who are really needing gene therapy for Stargardt or RP like?
Well, very difficult question to answer because trials are quite a few are unpredictable. Now the best part what we realize is, yes, most of the time, as of whatever data available is in particular Laksana and couple of other trials, and we are also involved in a couple of trials working with actually IIT Kanpur and other institute in Chennai as well. So probably animal studies are good. They are looking at mainly one single injection, what initially thought probably you have to give repeated injection. Almost 7 or 8 years data is available that one single injection probably works. So exact answer I do not have how long it will take, but what you have problem here with, because all these diseases and retinitis pigmentosa, for example, there are 150 gene defects are there. Stargardt's having a few more. So you have to be very, very gene specific, and what we are talking about, most of the research going on like RPA65, and the incidence of that is somewhere whatever we have, like maybe 2 or 3%, so 100 are patients when we have for RPA, only 2 or 3 will be having RPA65, and those are the limitations. The number of patients are very limited. So now each gene will need different specific drug will have to, when our vector is same but different specific gene correction. So that is anybody's guess, but probably once technology is developed, as we see other instrument equipment, initial phase is a very long 10, 15 years, but once this starting and one thing comes, and when you know the process, probably things will move faster. I am not answering your question correctly, but I do not have really exact answer for that. We'll wait for over the 5-10 years.
So because especially for retinitis pigmentosa, there are a lot of patients who are waiting eagerly for a long time as to what new is going to come.
Absolutely.
And they come back every 1 year or 2 years.
Yes.
I keep telling them there's something going on research. Once we get something to know about it in a concrete way, we'll be able to deliver something.
Yeah.
So that is one aspect, that is one disease which lot of patients are waiting still.
Yeah, it is frustrating for them, frustrating for us also, because I know a couple of my colleagues now settled in US. Last 25 years, they are still working on, see, the stem cell is gone. They tried bionic retina, electro retina chip and everything, that also is gone now. So sustainability, that is going to be question for all of us. Like we need a long-term outcome. So even though treatment is available, unless we are sure about long-term outcome, 5 years, 10 years, long-term studies, we will not be able to very sure to tell them, yes, it works. Because we are talking of this patient, they are going to live next 30, 40, 50 years.
Exactly, sir. Exactly.
We need answers for that.
Yeah.
So we'll take time for
and
that.
And just one additional information about regarding the artificial intelligence, sir, especially in relation to glaucoma. I mean, there are various studies which show that you just take a good disc photograph, and that good disc photograph can be interpolated with the field as well as the neuroretinal rim and the RNFL defect. I mean, just one good photograph with the feedback that the AI has in its store, it can reflect on the fields also, it can create a field. So one test can replace multiple number of tests that are done for glaucoma patients.
No,
I mean, that is also in the offering, sir.
No, the glaucoma I included, I didn't say, but glaucoma, yes, that's
exactly.
One more emerging field. And what actually we were looking for, if I was saying as a kid, we used to go by train and railway station, we used to have that machine for weight.
Exactly.
You stand on it and machine come, and all used to be very happy with reading the whatever your fortune written back of it. So something like that, whereas people are looking at vending machine, you stand in front of it, it will scan your eyes, it says, okay, you are perfectly normal. Or you have diabetic retinopathy, non-proliferative. Have a checkup every 6 months. Diabetic retinopathy, proliferative changes, consult your surgeon to get a treatment. I think the stage will come soon. But what also few papers are there, what they did, reverse engineering. Put data and whatever outcome they got in that patient, okay, reverse engineer that. So it should actually reflect back the same what you feed in. But turn out to be very funny really outcomes to that. So still we are not to that stage really to implement fully.
Actually what you exactly said, what you feed you get back.
Yeah.
So it depends on the quality of feed that the machine is getting here.
So let's talk about garbage in, garbage out. So and they need thousands and lakhs and like some 50 lakhs images. We have tie-up with Google, Microsoft, Zeiss they are working with. And all these images, particularly lot of work on diabetic retinopathy. So thank you very much.
So thank you so much, sir. And we have the next speaker, Dr. Love Kochgave, and he is going to speak on pediatric lens subluxation. we don't need to introduce Dr. Lau Coach Gave, or do we need to introduce Dr. Lau? I think everybody knows Dr. Lau. Lau nahi sun raha, he's not listening to us. So just a brief introduction of Law. Law is a national, international pediatric ophthalmologist from Kolkata and known to everybody.
Thank you, sir. Thank you so much for the kind introduction. And this is a topic which is very close to my heart, and that's pediatric lens subluxation. And actually, if you see in cataract surgery, one of the most complicated and difficult surgery would be subluxated lens. And in pediatric subluxation, what you see, this is a brief introduction, and these are non-cataractous lenses mostly, non-traumatic and progressive, leads to high myopia with high astigmatism. Visual acuity drops as the lens margin, equatorial margin, starts approaching the visual axis. So the dilemma is whether we should operate these cases or not, and when to operate, and what are the surgical options. So what I do generally is that when the vision drops below 618, 624, then I tend to operate them, and generally at an age of 7-8 years and beyond, because then if you need to do some scleral fixation, that is the safe age to do it. Now in surgery there are various options. If you want to preserve the capsular bag, we have a Ahmed segment and Sioni ring. And if you want to sacrifice the bag, then we have the conventional sutured scleral fixated IOL or the glued IOL. So let's go to the first surgery option, which is with Ahmed segment. And what you see here, first, if the pupil is not dilated, dilating intraoperative lignocaine and tropicamide combination is available now that we can do. And once we start initiating the rexis, this is probably the most difficult step when you are doing a pediatric lens subluxation. So what you see after the initial small rexis, the capsular hooks are used, the lens is brought to the center, then the CTR is implanted. And after CTR implantation, the cortical aspiration has been done. Single piece lenses are easier to implant in subluxated cataracts or subluxated lens, because there is less manipulation in implanting the single piece lens in the bag. And as you can see, once the capsular hooks were removed, the anterior capsular opening is grossly decentered. So we made another relaxing cut in the anterior capsular margin and tried to enlarge it and remove the subluxated area of vitreous fibers. The scleral pocket is made, and now comes the stage in which we have to fix the bag to the sclera. And there are various techniques. This is one of the technique in which we have used Ahmed segment. The central eyelet is we use 9-oproline or 10-oproline. 9-oproline will be safer because future cutting through the sclera and then subluxating again, chances are much less with 9-oproline. Using railroad technique, the sutures are brought to the scleral pocket and little bit tighter, because with time it will loosen up and then the lens will come in the center, and what you get at the end of it is a good centered IOL. Next option is using a Sioni ring. First few cases I did Ahmed segment, and then one case we decided to do a Sioni ring, and as you can see, this is a gross subluxation, almost 180 degree or more. Again a capsular rexis is done. First the capsular hooks are implanted, put, and then the rexis is completed, scleral pocket made. And then before cortical aspiration, as you can see, before cortical aspiration we try to implant a Sioni ring. The problem with Sioni ring is many times it seems to be larger than the subluxated bag. So while implanting it in the bag, we have to be very careful that the leading edge does not move out of the bag then, because once it does that, then it becomes very difficult to put it back in the bag. And here, as you could see, it has gone in very smoothly, and then the eyelet of the Sioni ring has to be brought towards the maximum subluxation, and that has to be sutured to the sclera. So once the scleral sutures are taken using railroad technique, then you try to rotate the Sioni ring, and that is a bit difficult with the subluxated bag. The movement has to be very gentle, because with there are chances that the subluxation may increase. The area where the zonular fibers are better, that too may give up. And this, at the end of it, you can see again a centered bag, and the single piece lens is implanted in the bag. So this is at the end of the surgery. You have and most of these cases, these are almost 8-10 years back, and they are doing well, maintaining 6-9 vision even now. Third option is this I discovered accidentally. When this one eye we had operated with a CTR, and that did well, the lens got quite well centered. When we started doing the second eye, we had not planned scleral fixation in this patient, but as you can see, the capsulorhexis has been done, the CTR is implanted, and I was not ready with any scleral fixation device in this case. So we implanted the CTR, a 3-piece lens in this case is implanted in the bag. We did a posterior capsulorhexis also, and then at the end of it, once you remove the capsular hooks, what you see, still the lens is subluxated, the bag is subluxated beyond our comfort level. So I had no option. I just used 9-oproline and used the CTR as the fixation device. But the danger here is you are cutting through the bag, and if there is manipulation, the whole bag will tear off, and the lens may become unstable. But definitely this is one thing we can, in cases in which we are caught by surprise, we can try this. This also did quite well, and was sometimes when the subluxation is very gross, it is always, sometimes when there is a gross subluxation, what we have to aim is to give good vision to the child, so there is no point. And if the child is less than 7-8 years of age, we can do a neat lensectomy, and again lensectomy, the choice can be either a pars plana route or a limbal route. Ideally, if you speak, pars plana route will be better, but since as anterior segment surgeons we are not trained for pars plana vitrectomy, I decided to do it with the limbal route. Only thing is that you have to be careful to remove all the cortical matters and the bag in toto, and for that you may have to rotate the eye little bit and see towards the fixed area of the lens. And a neat lensectomy, the child being left aphakic for a future scleral fixated IOL will do equally good. The main purpose is visual rehabilitation. Only thing we have to stress with the parents that spectacle usage is must, and the child should be using spectacle 100% of the waking hours. Now next comes, again it is a controversial thing. Many people who are against bag fixation will say that it is a progressive disease and eventually the bag will give way from the other side, and this is one such case in which few years later the other side gave way. So what we did here is just one fixation suture through the fibrous bag, and the lens comes back towards to the center. So if you are planning to preserve the bag, there is no harm in that. Only thing, if you have to be ready in future, if the other side gives way, a simple 10-minute procedure will bring the bag again back to the visual axis. And what you see here, we have again piers, we have used the haptic optic junction as the anchoring site, and from there we have piers. We went through the capsular bag using a 9-O-proline. It is and little bit manipulation. As you can see, the needle was not bent as I had wished it to be. So little bit of manipulation, you bring it out, and through the same scleral pocket, bring it out again using the main port itself or a small side port. In this case, you don't need to make a main port. A 1 millimeter, 1.5 millimeter side port is enough. And here it is brought back and again anchored to the sclera. Now comes the fourth option, and which is again, if there is more than 270 degree subluxation, there is no point trying to do or if you are preserving the bag, then you have to fix the bag on both the sides. It cannot be done one side. So in this case, we just did a lensectomy with a scleral fixated IOL. Again, glued IOL or a sutured IOL, that is a matter of debate, and I think the surgeons who prefer glued IOL, they have a very valid point that donesis of the IOL is much less in glued IOL when compared to a suture fixated IOL. But again, it depends on the comfort of the surgeon also. So in this case, we did a lensectomy, and with the high speed cutters, things have become much more easier, and we have to take care that cortical fibers don't fall back in the vitreous cavity. Once this is done, PMMA scleral fixated IOL is implanted, and generally these are very good, well centered IOL, and the child does well vision wise for a very long period, and till now luckily we have not found any complications in almost 12-13 years of follow up in these children if the surgery has been done neatly. So thank you so much, and thank you again Dr. Salab, Dr. Pallavi, for giving me this opportunity. Thank you.
Salab, very nice surgery, nice and clean as always. In some of the cases, I'm just giving example of the adult subluxated cataract, where you find the subluxation little less than 180 or so. If I implant or if I put CTR inside and put multi-piece lens in the sulcus with optic capture and taking care that there is no vitreous in anything,
that will also do very well.
In pediatric, how do you feel that it will be different? Or
even in pediatric you can do. See, main purpose is the IOL should not get decentered over a long period of time. And if you are using a 3-piece lens with optic capture and the haptic in the sulcus with a scleral fixation, I have done. Some cases I have not shown. Some of the cases in which I landed with complications, the CTR, the fixation device, was used as a support and the lens was implanted. These children are also doing quite well even now.
What you rightly mentioned, that implanting a 3-piece lens is more difficult than a single-piece lens, because the behavior of the 3-piece lens inside the bag is unpredictable.
Yes.
It can go haywire also, whereas the single-piece lens is always comfortable.
And manipulation is much less in a single-piece lens when you are implanting.
So have you used a T-flex lens which comes with Apaswamy for the scleral fixation? Because that is very easy. I have gone through the literatures and all. I was planning to implant it.
I have not used that.
So that is one thing which can be done by everybody, and that comes in different sizes also for pediatric as well as adult. It has got a crescentric kind of a thing. You just have to pull it out and it anchors well in the scleral groove that you create.
Okay.
So just take out and that gets fixed both sides. So that is easy, and that is a hydrophobic lens also. Foldable hydrophobic lens which can go through a incision size of around 3 mm.
Okay.
So that is a very good option.
Thank you.
Yes, it's a very simple way of doing it, but I am little bit hesitant because these are just IOLs they are last 2-3 years. This Niven Marivanan in that C loop, like a basic T loop T shape. So you need to flatten those. Once they are out, and you put a conjunctiva scleral flap over it. We are looking at again 30, 40, 50, 60 years, what we used to see previously very comfortable with Prolene, and we realized down the line 5 years, 10 years, and now they are coming with snap suture or something. So with this, what are the chances of erosion? I do not know, because you press it, yes, memory is there, but slowly when they start coming up with your eye is moving, leads are rubbing over it, we'll have to
Sir, what is your preferred choice for these kind of subluxated scleral fixation? Still you do with sutures?
I prefer suture, but now shifted to Gore-Tex.
Achha.
But then because we were looking at those previous results, because Prolene experience was almost 15, now 20, 25 years, few are holding on still, few are snapping anytime after 5 years, and particularly pediatric age group. So then we started using Gore-Tex. But Gore-Tex 4, 5, 6 year, very peculiar thing, sclera overlying is getting necrosed or eroded. Not all the cases, at least I have 1 or 2 cases. My other colleagues Chetan and Pradeep and Atka, they are having again, each one has 1 or 2 cases. We have done a lot, but don't 1 or 2 cases which never happen with Prolene. But here sclera getting necrosed, and at least one of my cases I did twice scleral praxis. Once I rotated a suture, rotated a scleral flap, and now I have scleral praxis over it. So again, I do not know where I don't have exact answer, but I am comfortable with that. Basically, I prefer doing complete vitrectomy these eyes. What you rightly mentioned, I was looking at it, is actually all these cases, there is no zonal loss. When your video is so clear, I can make the zonals are there still. They can see, they are lax, only thing. That's why lens is subluxated. And then trauma versus congenital disorders, having a progressive disease. So long term, again, few cases what you are seeing is entire bag lens
will fall back.
With even your capsular tension ring, everything is now dislocated in the vitreous cavity. But it does not happen in a trauma, because trauma is one single one-time event. So we'll have to watch for this. Pediatric is always mystery and difficult cases to handle. Well done, I think surgeries are exceptionally
Yeah,
good.
there is no ideal solution to this. There is no ideal solution to this.
Thank you, Law. Thank you, Dr. Law Kojgawe, for the wonderful videos and that you showed. And they're really nice. We have become wiser by looking at your videos. Thank you so much.
So he is son of the soil, and we are very proud of him.
No, he's not son of the soil. He's become a Calcutta person now.
No. He is son of the soil. हमारे बिहारी बाबू है. So I will.
क्या है ना कि just like Partha Biswas, when he is in Bihar, he becomes a Bihari Babu, right? And so both the people are in similar situation.
No, he is an excellent surgeon, and very humble, very polite, and does excellent surgeries, and he just showed us some of them. And I will request Dr. Pramod Bhende sir to please felicitate Dr. Love.
Now I would invite Dr. Pranav Ranjan, President ISOC, for the memento as a chairperson.
Okay.
Dr. Pramod Bhende, acha chale gaya sir. Sir, okay. Kindly grace the stage again and give this memento and our regard to Dr. Pranav Ranjan. Sir. आप वहीं रहिए ना, यहाँ की बातें चेक कर रहे हैं. Now I would invite next speaker, next chairperson, Dr. Subhash Prasad from Patna, and I would request again Dr. Bhinde to present this memento as our gratitude and respect to Dr. Subhash. I would request Dr. Abhishek Kumar to come forward and receive his memento as a chairperson. Dr. Pramod Bhinde again, thank you so much, sir. मेरा लिए कि नहीं भी? मेरा लिए हैं? लीजिए जल्दी. Now, Dr. Partha, लाएंगे ना? आइए. say something about him? जहाँ कंफर्टेबल हो सर, ठीक, उनके बारे में बोलते हुए बुलाइए, चीफ गेस्ट हैं हमारे।
सर जा रहे हैं। हाँ, हम लोग सभी लोग जानते हैं डॉक्टर पार्था विश्वास did his MS in Patna Medical College and then went to Calcutta, started his practice, and he was associated with BBI Foundation for many years. He was one of those pioneers in Calcutta who started LASIK, and along with Dr. Ajay Paul, they took BBI Foundation to a very big stature and height, and it became a very famous center. Now sir has another center, that is Netralaya, where he started smile surgery for the first time in Eastern India. And we know that sir has been very active in the All India Ophthalmological Society. He has been chairman scientific committee, he has been chairman of the ARC, and now he is vice president, and next year he will be installed as president. It's a great privilege and honor that sir accepted our invitation and agreed to come here, and we have invited him as a chief guest, and I'll request Dr. B.S. Jha sir to kindly felicitate Dr. Partha Biswas sir. And sir will now present the surgery that he just finished some time back.
So thank you very much, Salam, for that very kind introduction. But I am going to take you back 32 years ago. 32 years ago, it was 1992, and at that point of time, I was in Rajgir as the Chief Medical Officer in Rajgir, and decided to do a conference that was allotted to us by BOS. So BOS allotted that conference. Shivas, I'm sure you would remember those days. And we planned to do live surgery at Virayatan for the first time. And in that live surgery, the surgeon who showed and demonstrated us phacoemulsification was Dr. Arun Sinha, sir. So it was a great moment for us, and it was the first live surgery that happened in Bihar, and it was a huge success. All stalwarts came from different parts of the country, and it was an eye-opener for us that we could also do live surgery in a small place like Rajgir with very small facilities. Today is a great moment for me because in the audience is my teacher as well. So you're looking around to see who is my teacher. It is none other than Dr. Pramod Bhinde. I was his first fellow at Shankar Netralaya, and I watched him as the first consultant after his fellowship when he took the position of a consultant, and the meticulous ways in which he did every step. And that is what the teaching of a consultant to a fellow was, and even till date is at Shankar Netralaya. So it's again a very proud moment that Dr. Pramod is here with us, and the galaxy that Shalab has invited all over the country. When I look through the names, my God, kaun nahi hai? East, west, north, south, everybody is there in Muzaffarpur. I think it was the lychees which drew everyone to Muzaffarpur, if not anything else. But thank you very much. Shalab, I'm really very sorry that I could not come in yesterday evening and missed so much of great work and great fun. Let me talk about, so for my coming late and for my not coming yesterday, so Shalab gave me a challenge. I did not understand. When I was looking through the microscope, I said, Baba, itna kam light hi pata nahi chal raha, and there is hardly any light. How can I operate? Then I cleaned the eyepiece, I cleaned the lens, but still it was like that. So this is what you saw, the view was when I was operating. And as I was finding my way through this patient, so it is a patient which has enter karo? Haan, theek. So this is a patient, and I think we have recorded a little late. We have done a good rexis. We have marked this patient, and it is a toric EDOF lens that was planned for this patient, approximately 1.3 diopters of toric. Now, it is very important to say here that today's toric lenses must be placed even if you do not have a markerless system, and the cylinder power is more than 1 to 1.5, 1 to 1.25. And it's very important also to look into the astigmatism with the rule and against the rule for a proper guidance for a toric lens. Now, this is an EDOF toric lens. What would have happened if we did not do a toric for this patient? He would have lost the beauty of the EDOF. Now, this is the patient. I'm operating on Stellaris. It's a very good equipment, but I'm operating after 15 years on a Stellaris. So we do a straight chop for this patient and go right across with the Sinsky and then just separate the nucleus, and it separates quite well. Despite the very poor light that Shalab provided me in his OT. So we try and take it around, and I am just able to see, yes, I have done a straight chop, and in just about 30% of illumination that we should be doing. So this is a nice and clear straight chop. So the quadrants is also important. So we always go in for the larger piece so that we are able to divide into the quadrants, and we can take up one by one the quadrants that have been taken up. So this is just about a grade 2, grade 3 cataract, nothing very, very significant. But of course the illumination was the problem, and I really did not know why this illumination was like this. Then we take off the epinucleus, and it comes on very well. The persons who set the parameters did a very good job, and I was able to get through with very, very small amount of energy. And as you can see, we have marked it quite well. And this is taking off the cortical matter, which of course I do with the bimanual. It can be done with the coaxial as well, but it just is to suit the purpose of the bimanual. So it's also important that we take off in these cases every bit of cortex that there is. Now, as I said that the illumination was very poor, and I was hardly able to see, but then suddenly Shalab came in and said, the microscope light is not on at all. So what I was operating on was through the OmniGlow illumination. And this is the task that Shalab gave me and pushed me into this, so that he makes up for all the sins of not coming yesterday. So in any case, challenge accepted, Shalab, and my apologies also. But next time say please aisa nahi karna yaar. So this is the lens, that's a single piece lens from EDOF, of EDOF. It's from the KF group and it's called the Magnificent. So we can place it in the irrigation, under the irrigation. So I take the irrigation right across the center. So I'll just stop here and just ask everybody, we are all placing single piece lenses under irrigation. Ashish? Nahi? Nilesh? Yes? Viscoelastic. Khabardar. This is my co-fellow from my PG days, and he still is using viscoelastic. Ekdam nahi. Viscoelastic nahi use karna hai to insert single piece. So it can be done under viscoelastic. It is much more controlled. It gives a lot of control while placing in, and as you can see that at times the lens will unfold a little on the side, and you need to be very, very particular that it has gone in properly and right inside the bag. So it's a well-centered Rexis, and we remove it, but now see what is happening is I detect that there was some amount of cortical matter still sticking to the posterior capsule. So I rotate the lens in the bag and it rotates very, very well. You can see the markings very well, and it's always important to rotate it the clockwise way and not go the anti-clockwise way. So in such a situation, the benefit of a toric being implanted under irrigation is that you do not have the visco underneath and you do not have to remove the visco underneath. However, the visco underneath can be removed quite well as well. Now look at this, that amount of cortical matter I've gone under the lens, and I'm just brushing across the posterior capsule to remove this amount of cortical matter which was sticking, and I had not detected that it was there. Otherwise I should have removed it before placing the lens. But this maneuver can also be done. It has to be very gentle and precise. In fact, you can go in even with the aspiration and take off those wisps of cortical matter, and they come up very well. Little control needs to be there, but it's quite doable. So again, placing the markings, the toric markings right into the markings which should coincide with the markings that we have made with the methylene blue, and that is more or less the end of the surgery. So Subhash, you would have done anything different in such a case? So let's have the hands up कि कितने लोग इतना कम illumination just OmniGlow में सर्जरी किए हैं? तुम उसी में करते हो? अरे बाप रे! So it was an experience for me. Anyway, everything went on well, but it's really it really gives the OmniGlow is such an excellent equipment that we have today. Yes, that also absolutely can be done. Absolutely can be done. So it's very important that those small cortical matter that stick to the posterior pole or the posterior capsule and right in the center, they definitely need to be cleared, because they are the possible sites from where the LECs also might come up, and you will have a very fast PC opacity and क्या? Stellaris, हाँ. You use the Stellaris, no? Yeah. Right from the beginning, yes.
For these kind of cataracts, especially for these kind of cataracts. I mean, soft cataracts, really, really good. All what setting I have been using for soft cataracts is that I put it in a pulse mode of around 6 to 10. Around 6 to 10. So off and on time is slightly longer. So off time, right being in the center, the nucleus, the cortex, everything comes to the center, and during the on time it emulsifies. So that is my setting, and that has given me a lot of safety. I've done a lot of cases with this, and I still feel that Venturi versus peristaltic, I always favor the Venturi machine.
Yes.
For all kinds of cataract.
Actually, sir.
Yeah.
So actually, all these high-end machines are excellent machines. We can never blame one machine to the other and say that I prefer this machine particularly. If a particular machine is not giving you the best of advantage, that means your settings are not right.
Exactly.
Even when we started with the Centurion, I felt that Centurion is a worthless machine. Infinity was a much better, faster machine, and I'm not able to take off the amount of the nucleus as soon as possible, and that was it. But now, of course, it is just the usage of the parameters and twiggling the parameters to the best of your advantage.
And second message from your surgery, I think it was a manual marking for the toric, isn't it?
Yeah.
So everybody should be doing a manual marking, because the difference between the final result between a manual marking and an image guided marking is hardly significant. So anyone who does not have an image guided marking system can easily on the slit lamp mark the axis and then put in the toric IOL. So that I think, that message I think Partho should
but
go
you
clearly
should
to
be
do.
doing the markerless system. What are you going to do with all that money that you're storing?
तुमसे ले लेंगे, तुमसे
For
ले
whom?
तुमसे लेंगे संजय के लिए इससे गिफ्ट लेना होगा.
ये नहीं हो रहा है क्या? हाँ, खोल के.
नहीं I'll tell you one thing. हम SIC जो है ना फेको करने के 5 साल के बाद करना शुरू किए. हम ECC से डायरेक्ट चले गए फेको में, आफ्टर 5 years बिकॉज कुर्जी में हमको कैंप करना रहता था 100 केस का, तो क्या करते हो उसमें. Then I started.
Once you start having this markerless system, then you will realize the advantages. Until unless you don't have that, you will always feel that yeah, this is giving also good result, but I think that spending 35 lakhs for that, so
My message is this.
Yeah.
It will not prevent anybody
Absolutely.
who does not have it.
Yeah.
Not
Agree.
doing a toric.
I think everybody has started toric without markerless system, so started with the ink systems.
That is my image. I mean, technology, you adapt to new technologies, absolutely perfect. I think you will agree.
So yes, that is what Pranav's message is loud and clear, that everybody should be using toric lenses, because it gives a huge advantage to every patient who needs it, who requires it. So now let us look into a few difficult situations in phaco, and I'll start with the best subject which draws attention for everybody. How many of us have had PCR during phaco surgery? So both my hands are going up. Love, एक हाथ तो उठाओ कम से कम. Dr. Pramod Bhinde. Okay. Okay. Okay, Pramod, I'm going to go back to that incident that we always talk about. Dr. Lingam Gopal was learning phaco, and Madam Dr. LV was supervising, and so she was guiding every step, this, and then he had a rent, and then the nucleus fell in. Then he said, now you can go. I'm quite comfortable managing this. Yeah. So this is the difficult situation that we always fall into, and I don't think I'll be able to stop the... so this is a big chunk of nucleus, and I've created a nice PCR, but the chunk of nucleus is there, And so here is a situation where you have to see if you can partition off the nucleus from the anterior vitreous and not let the vitreous come into the anterior chamber. So I'm able to do this with high molecular weight viscoelastic. There are other ways to skin this cat, and taking off this amount of very soft nucleus very gradually with the phacoemulsification. Very important is at any point of time, if I feel that vitreous has come into the anterior chamber, immediately I need to stop. So replenishing time and again, and with high molecular weight viscoelastic and methyl cellulose, we are able to take off the cortical matter and remove most of the cortex. However, placing the IOL is most important, and here of course the most favored IOL would be a 3-piece IOL, and that to be placed in the sulcus and with anterior and with a capture of the anterior capsulotomy. So we place this, and but what is very important, and this is something that our VR surgeons always tell, that we need to be very judicious. Is there a bit of vitreous at all in the anterior chamber? And that needs to be checked with the triamcinolone acetate inside the anterior chamber, a good wash, and if it is not there, then you know it is not there. So Salab, in such a case, would you do anything differently? As I said, there are many ways to skin this cat, and there is a very important technique that can be done.
So what I would want to check is that I would try and do a little bit of anterior vitrectomy first, and then use the vitreous cutter itself to remove the rest of the cortical matter.
Yes.
Because I'm sure there is going to be some vitreous there. And had it been a slightly harder nucleus, I would have placed the intraocular lens over the iris, and then done the phaco.
So scaffold technique. So scaffold technique is a very good technique, and it should be employed whenever you feel that there is a need for a scaffold technique. Now look at this another situation where everything is going on very well and all is done well. Everything gets cleared up, the nucleus is gone, the cortical fibers are all out. But at this last moment, what have I done? I've created a PCR and right in the middle. So with a PCR as this and right in the middle, what we can always do is to create this PCR into a PCC. So the PCC, if it comes in, and it is nothing very, very difficult, viscoelastic in the anterior chamber, not too much, not too full, but just optimally, and then with the microforceps going around and making a PCC out of this. And then even with a bulky lens, as a single piece lens like this, it will very nicely go into place. There is no possibility of extending this PCR, which has been converted into a PCC, and that would be a good way. But however, it cannot be possible in every way. It's only when you can see that the edge of the PCR is something that you can make into a PCC, and then only can be done. Now let's look at another situation, and in this situation it's a posterior polar cataract, and this posterior polar cataract, I've already seen that there is a dehiscence and there's a rip right across. So what I am doing here is I'm trying to take off the cortical matter, which is a thick amount of cortical matter, and placing viscoelastic from the side port and removing it very, very gradually, and it gets removed very well without the vitreous coming in. This was a youngish patient. Then what I do is, can I place a single piece lens in the bag? This patient, I had thought of a single piece lens in the bag. Now, so what I do is, I place a blob of high molecular weight viscoelastic separating the two edges, that is the posterior capsule which is torn and the anterior capsule, and then rotate the lens, and under direct visualization place the haptic of this lens between the torn posterior capsule and the anterior capsule. Now this is a situation that cannot be done every time. Now look at the way that it has to be twiggled in, and having the elbow on the angle of the haptic. So this is very important, and once it goes in, it has to be ensured that it has gone into the right place. If it has not gone into the right place, this will decenter, this can fall into the vitreous also. Again, it depends upon the acumen of the surgeon, and if the surgeon has the acumen and if the situation can warrant it, then this is also a possible method that we can do. Single piece lens in a torn capsule where it is like a hammock, and you can see and direct the haptics right in between the hammocks of the torn capsule. Subhash. सब केस में नहीं कर सकते हैं, especially vitreous जब आ गया है तो बिल्कुल नहीं कर सकते.
Okay, so that's true, sir. Once the anterior hyaloid face is not broken, only then we can try to put the haptics in an area where we have sufficient support of the posterior capsule. So, and at the same time taking care not to let the anterior chamber fluctuate any time. That is very important.
Absolutely. So this is not for all situations, but it can be done. Dr. B.S. Jha.
This case, as I see, there is hardly vitreous in chamber, so we can safely end the surgery.
And again, provided the anterior capsule and the posterior torn capsule opens up. If it does not open up, then you don't have the space. And under total visualization, because whenever there is a PCR, there is manipulation, and the pupil might shrink also. So before the pupil shrinks, and if it is wide and you can see it well, then only such can be done. Now, traumatic pediatric cataract दिखाएं क्या लव? वो फोन पे बात कर रहा है, चलो तब तक दिखा देते हैं जल्दी से. So this is a traumatic pediatric cataract, and I do not know what to expect out of this cataract. So, but we have marked the center, and we see that there is a huge amount of synechia there, but it looks quite well, and you can see the large cut on the cornea. And what we find is that there is a possibility that we can go ahead and do a posterior anterior capsular excess. And here, of course, the anterior capsular excess, because of the pediatric capsule, has to be done with a microforceps, and it has to be done as well as possible, as central as possible. Now I'm going to face this challenge whether I am able to do this well enough, and whether it is going to give way or whether it is going to run into that part. Usually when fibrosis has taken place, that part where the anterior capsule has been torn is very, very strong. It will not run out. So my intention is to have this anterior capsule as much as possible, as round as possible. Now it was not too round, so we make a small nick and then go around and try to make it as round as possible in the anterior capsule. So this is quite a kidney-shaped anterior capsulotomy that we have made. Now, hydrodissection in this case is definitely controversial because you don't know what is the status of the posterior capsule, but I do a very, very gentle hydrodissection and very gradually I remove it. Now, we had also done a USG, and on the USG we did not notice a posterior tear that was very evident. So we remove this amount of the cortical matter from behind, and the removal of the cortex is not too difficult. So once the cortex is removed well, so you know where you stand. And in all these traumatic cases, it is the decision on the table that actually has to be there. And here we see that, that big rip is there, it is quite fibrosed, and the posterior capsule is intact. Now, of course, if I have to show it in front of Love Coach Gave, I have to do a posterior capsular excess. So I'm doing a posterior capsular excess, and with the micro forceps, we take it around, and this posterior capsular excess is done. It has to be done because that central opening is very important, and of course, the lens can go well in the bag. Of course, without doing it with the microrhexis forceps, it can also be done, and Love is very fond of using the vitrector for doing the posterior capsular rhexis, which is an excellent way as well. And of course, it is easier at times as well. So we need to remove it, and now I'm doing the anterior vitrectomy so as to remove the scaffold of the anterior vitreous, and checking whether there is any amount of vitreous in the wound. Love your comments. Shall I continue doing pediatric cataract surgery?
No, very well done. And this is what Dr. Asim Seal described as seat belt capsulotomy.
What
seat belt capsulotomy.
Seat belt, achha.
That means that the central, that band was will hold the lens in the center.
Okay.
It will, in long term, it will never decenter. So this is very nicely done.
Shall I, समय है एक और वीडियो दिखाएं? हाँ समय है तो अच्छा ठीक. So this is again a very favorite video of mine, and I try and show it whenever is possible. So microspherophakia, again a very challenging case, and so this was at a time when this is so when we did not have the femtolaser cataract machine, and when we had it, so era before that and era after that. So microspherophakia, Love has shown already the difficulty of puncturing this anterior capsule, which is so lax. You can look into the number of zonules that there are, in fact. And this whole lens goes here and there. And doing a capsulotomy manually is one of the toughest tasks. And if that is done, most of the other parts are quite easy. So we take nearly 5 minutes to do this anterior capsulotomy. It comes on well, and it is quite well done. Now placing these iris hooks so that they hold the capsule, it's not possible in these cases to place the capsular hooks because the flange of the capsular hooks are much too large. So we place a single piece lens, and then we put in the two Ahmed segments into the bag, and then suture it by the railroad technique, and this gets nicely sutured, and it is well centered, and this patient gets back very good vision, and patient did not have glaucoma, and this is the condition of both the eyes after the microspherophakia surgery in both the eyes. So you can see the amount of fibrosis that takes place. So the capsulotomy is one of the most important things that we have to do, and to do very well in these cases, and that is where the challenge is. So the next sister, she comes in, and the whole family had microspherophakia. In fact, we presented this at one of the ACRS and won awards also for this movie. So here is the catalyst which is employed to do the anterior capsular rhexis. So the catalyst will do an anterior capsular rhexis in just 1.4 seconds. So here, of course, we have to twiggle with the parameters a little because it is a thicker capsule, and you can see the full round lens, the spherophakic lens, which is nearly round shaped, and we do off the capsular rhexis with the femtolaser, and that's what was required. Now we do a Hoffman's pocket in this patient, and once the Hoffman's pocket is done for anchoring the lens ultimately, the bag complex ultimately, so it's important also the Hoffman pocket is a very elegant way of anchoring and should be done. Now look at this capsular rhexis. When I'm trying to pluck it off, it takes quite an effort and strength because the amount of energy setting that I had done in this femtosecond laser is not sufficient enough to fully open out, and you can see that it's like a postage stamp mark. So in this postage stamp mark, there is always a possibility that if you are not careful, the rhexis might run out somewhere or the other. So we are careful here and take off the whole of the nucleus. The nucleus is very soft in these cases, but what's important that the zonules should be respected as much as possible. So once that is done, then again placing these iris hooks to stabilize, and then placing the single piece intraocular lens inside the bag. Now These are small bags, but the single piece intraocular lens from Alcon, I have no financial interest. The haptics are so pliable that they can crowd upon and get fixated very well, and we are able to place these haptics in the bag without any difficulty, or just with a little bit of crowding on the optic. But that doesn't actually hinder any of the processes. So we have to anchor this, and the anchoring is important. And once it is well anchored, these lenses stay well positioned for life. Of course, microspherophakia would have a tendency of glaucoma, and these patients have to be cared for life. This patient was of 22-23 and is still maintaining very good intraocular pressures. Now look at this in the mid-dilated pupil. The small bag has just space enough, and the AMED segments are nearly approaching the center of the pupil. So these are aspects that we have to consider. Thank you very much for your kind attention.
That's when I first met Dr. Sudipta, and that is how far back we know each other. As I even mentioned yesterday, the 3 years that I spent in Nagari Eye Hospital, the seniors, the teachers, the relationship that we built with each other is probably the reason why whomever I have invited has come today. And Dr. Sudipta made sure that I don't, like Kamar sir mentioned yesterday, that I was a mischievous resident. So Sudipta ma'am ensured that that mischief was to the minimum. And I will request Dr. Sudipta. Now she is in Calcutta and she is working in many centers. She is doing phaco, she is doing smile surgeries. So she is doing very, very well. She is extremely active in academics. She is presenting in the West Bengal Ophthalmic Society, in the Eastern Zonal Ophthalmic Society, also in the All India and DOS. So she is extremely active in presentations, and that is because she has done such amount of hard labor, because it's not easy in Calcutta to make a name for yourself. There are so many stalwarts in Calcutta, but Sudipta ma'am has ensured that she is climbing the ladder, and she is climbing the right ladder. So Sudipta ma'am, please.
Thank you, Salah, for that elaborate introduction. Yes, we were residents of Dr. Usha Ben Vyash, and it is indeed a great pleasure and an honor. Thank you, Salav and Pallavi, for allowing me to stand here and present in front of Dr. Usha Ben Vyash and Dr. Bakulesh Bhai Khamar, who were there, who taught me ophthalmology. And of course, Dr. Partho Biswas and all, who influenced me into refractive surgery. Salab said he was my junior. Salab, we are now friends, and you have climbed the ladder so well with Pallavi that I am following you. And your mischief, I'll take 1 second. So while we were residents, we were asked to stain the anterior capsule with trypan blue only when it was required, with a white anterior capsule. So from the very beginning, Salav used to stain most of the eyes. So I said, why are you wasting? Why are you staining all the anterior capsules which were not white at all? So now, Salav, let me admit and let me tell you that in most of my cases, I stain the anterior capsule even if it is not white. So I have learned for you. Thank you so much. So, not wasting any more time, my topic add-on IOL beyond lasers. Now, as Sala was saying, we have so many stalwarts, not just in Kolkata, but everywhere else. And as Dr. Pranab very rightly said, that we adopt technologies like multifocal IOLs and very good IOL machines. So, the patient's bar of expectation has also risen. So patients are not expecting just vision after cataract surgery, good vision, but now it has become somewhat like a refractive surgery. And they expect 20/20 vision even after cataract surgery, 20/20 for distance and N6 for near. So, and we are actually giving most of the doctors who are doing cataract surgery by flags or otherwise, like in this hospital also, I'm sure. So, what happens if we fail to do that? So, that is where my role comes. We all know that this post-refractive, post-cataract surgery surprises are a bit annoying and they create trouble for us, especially a headache when we are putting a multifocal IOL or we are doing some surgeries where the patient is very demanding. So let me just quickly go back to a small introduction. This was 1993 when Gayton and Sanders had first thought of this piggybacking of IOL using two IOLs, one over the other in a microphthalmic eye for providing sufficient plus power, the correction of post-operative residual refractive error. So for this, we actually have lasers. As we all know, we advise laser top-ups, which is there. And another option, a very good option, was nothing else was there, was a IOL exchange. So that is always there. But this I'm going to talk of is a third option. Why? Because sometimes we cannot do a laser top-up, especially in a hypermetropic residue. Secondly, if the cornea is not sufficiently thick, and IOL exchange in certain eyes is a bit cumbersome and risky with a thin posterior capsule, or if the anatomy of the eye is not that good, then IOL exchange actually does not pay because we might hit the posterior capsule or might not get the result what we actually aim for. So piggyback IOL, and this was usually one IOL is inserted over the other in the capsular bag. That is a piggyback IOL. And what I'm going to talk about is an add-on IOL. Here, one lens is placed in the bag, the primary IOL, and we place another one in the sulcus. Now, why we shifted from piggyback to add-on? The reason was that in piggybacking, it was seen there's an increased risk of interlenticular opacity. As the lenses, they sit together in the bag, so sometimes there's interlenticular opacity. So when you are going to correct a post-operative refractive error and then finally you get a PCO or interlenticular opacity, then the whole beauty of doing it is lost. So naturally, this was the reason why piggyback went off. And there are some complications which are more with piggyback IOL, like chafing of pigment epithelium. And there is a theoretical possibility that both the IOLs might press on one another and there may be a refractive error. So these were the reasons why piggyback, the people started thinking of add-on IOLs, and piggyback IOL went obsolete. So any of these complications are much less when we paste the second IOL in the sulcus. Now this is not something that we regularly face, add-on IOL, and I also did not have much knowledge when I finished my post-graduation and successive days. But, so I'm going to talk of my experience, how I came into it. There is an audio here, is it, I don't know if it will be. So this was something, exploration which I did because I had to face this particular patient, the problem that I face. I have no financial interest in anything that I'm going to disclose. And this IOL, this patient in particular was a very high myopic patient, young adult, and with minus 33, 35. She walked into my clinic during the COVID times. She got a subcapsular cataract, posterior subcapsular, with a high myopic fundus, but fortunately, USGB scan, she did not show any posterior staphyloma. Now, we had very high axial length, minus 35.95, 35.12, so, and the IOL diopters came to minus 19, minus 18. So what next? We had very limited sources during COVID times. This was in 2021 end. So we tailor-made, and this is what we got, minus 1.75, minus 12 in each eye. We targeted myopia because these patients see well for near. So we targeted myopia for these patients, but this is what we got. So now many of the doctors wherever I presented had said that why didn't you go for IOL exchange? A very, very relevant question. The IOL exchange would have made me go back to the same company who tailor-made those IOLs, and I'm not sure if they actually gave me 17.5 or 17 or minus 18, whatever. So again, going for an IOL exchange would maybe end up in the same hypermetropic state as before. So this was the reason why I stopped thought of something else beyond IOL exchange. I sat down tight, and if Dr. Parthaviswas remembers, sir, I think he remembers, he advised me keep quiet, Sudipta, and stay calm for 1 month. So we sat down tight for this patient, and I was wondering what to do next, because with so much of hypermetropia, I don't think a laser would be successful. So what next? And finally I went through literature and found out that we could do something for her, which was known as an add-on IOL. These are the parameters, because you know why I wanted to do something for this patient, because she had some type of vision for near. She was just 28, and if making her hypermetropia, I was going to give her glasses both for distance and near. So these were her parameters, and as you can see, she had a very good AC depth, and the cornea was not very irregular. So all this was prompting me to think of something which I could put over the IOL. And I did a digital measurement of white to white. This was the correction that we had, 4.5 right eye and 1.5 a bit of cylinder in the left eye. So we decided to go for a Sulcoflex IOL. Now I had heard of Sulcoflex, which belongs to Rayner company, but at that moment in 2022 we could not get foreign IOLs at all. And Sulcoflex, till then I could not talk with anybody who had a previous experience except the company data which said it would do well. So with all these possibilities, I counseled my patient, was very cooperative, I must say, because she wanted some sight without glasses. That is where we were working. So finally, I'm sorry, again, I'll just show you. I'm sorry for that. So we finally went for this IOL, and this is what I did. I think anybody who is doing a normal IOL and an IPCL would be very comfortable when using these IOLs. It has thin haptics, 4 haptics. This is the IOL, and feeding is very, very easy into the cartridge. We were using a simple HPMC for it, and the formula that we used was something that I got from the literature. So that's what I banked on, and the company also said we have our own patented formula. So this is what I used for that particular case, 1.5 with whatever spherical equivalent she had, and we used IOL of 6.5 diopter in this. This is how the eye looked with the primary IOL in the bag, that minus 17.5, and we just like a IPCL, as we are people who do phakic IOLs, this we made 2 side ports and 2.8 main entry, and we guided the IPCL. This is a hydrophilic lens, let me tell you. So we guided it with the spatula in the left hand, and this was my first experience, my first surgery. I was a bit apprehensive what I would do. Only thing which I learned over time is you should not deliver it in the bag. That is the main thing that happens. You have to deliver it below the iris or over the iris, and you can tuck it back. Believe me, see, this is the leading notch which you have to take care of to understand that it is not in the other side, it has not tumbled. So I use that spatula to prevent that tumbling, and then you just simply tuck it the way you tuck phakic IOLs, and then ask the patient who is in topical to match the Purkinje images after a thorough AC wash in between the IOLs, because that is very important, because here you have 2 IOLs and you don't want opacities, otherwise the beauty of the surgery is completely lost. So after a thorough AC wash, And I did a PI, I did a peripheral iodectomy because I had no knowledge of this. So I was very apprehensive. Using 2 IOLs in one eye might end up in glaucoma, although she had open angles. And by God's grace and blessings of all my seniors and teachers, so this was the eye, how it looked. She had very good AC depth, she had very good post-op vision and 6/9 unaided vision. So the other eye also we did. And finally, this is how she looks now, 2 years after surgery. This is how she looks now, and we've followed her up with post-operative. So this is my experience. High myopic cataract patient post-operative, early 22 we did this. This IOL has a optic of 6.2 millimeter and 14 millimeter haptic size, and with no financial interest, it was manufactured by Care Group, who really helped me in this because I did not have any experience from my own or any colleague to share with me. Finally, we kept on. These cases are not very frequent, but suddenly I got few cases, some done by me, some done by others, and we got a series of cases, and we published it in 2023 in IJO, September 2023. And then now we are working on another series where I have put Sulcofix in a myopic astigmatic residue. So this was the post-op picture of the first case. As you can see, the angles are open, and this is the AS OCT. If you can see, this is how we understand the 2 IOLs there, one over the other, and this is her anterior chamber and very well preserved endothelial cell count. This is the second case, and why we did this female, we had to do a myopic residual astigmatism, we had to do a Sulcofix. The reason is the patient had undergone flax. One eye she was 6'6", and the other eye it was a high cylinder of 2.75 minus with minus 2.25 cylinder, both. So this patient was highly dissatisfied because she had severe issues with depth perception. And the reason why I had to go for this was not operated by me, either of the eye, the primary IOL. So again, here we saw the amount of astigmatism she had. She got good AC depth, and we counseled her for this, and we could have gone for laser. But this case, I wanted to find out if I would be successful. But she also had some retinal issues, so that was another behind my mind why I couldn't do a laser on her. So finally, we did this, and this is the lens that we used, +4 with -4 with +2 cylinder, toric IOL, similar to phakic IOL. The markings are there, and this is a customized toric Sulcofix IOL. So it was easy because we just placed it at 0-180 degree axis in this case, and the result, of course, the result was very, very good. This is the post-op picture, the AS OCT, and we did get a 6/9 in this patient, and this patient just followed me up 3 days back. She's absolutely happy. Her pressures are controlled. Although she has 2 IOLs in one eye and one, she has no problem with anything. So that's it. And the message that I would like to pass is this is a novel device which we can have in our armamentarium, because as phaco surgeons, as cataract surgeons, we do have surprises which we need to deal, and this is quite safe, very easy learning curve for any phaco surgeon who's doing, and a phakic IOL, of course, refractive surgeon, because it does not require any elaborate machines, and you can do it in your normal OT setup. So you just have to learn the process a bit. So I think it's very cost effective as well, because these lenses are not very costly. And please believe me if I say all of my patients did pay me for this secondary IOL. So I don't know if that's ethical or unethical, but my patients came up on their own and they did pay me for the secondary IOL. So this does avoid complications like PC rent or back dislocation. So it is a good thing that it's also available. It's easily available. Takes some time because they tailor-made this IOL according to the power that you calculate. And I do not know the exact formula how they calculate the toric IOL. That is patented with them. But they are very helpful, at least. So thank you for your patient hearing. And I wish Pallavi and Salav grand future. And as Dr. Prashant was saying, 55 years. So do invite me in the 55th year also. Thank you so much. Thank you.
Please stay, Sudipta. Please. Question from Dr. Subhash Prasad.
It's not question, just want to share the same experience he had. I have implanted this in 5 of my patients. 3 are actually pediatric patients who had undergone surgery long back, and they actually, because of the elongation of the eyeball, these patients actually developed myopia. So I have used in 3 patients and 2 in adult patients, the post-operative.
So they were myopic residual?
Yeah.
Power.
And in 2 patients, toric also, all are doing very well. And the best part is that it's very cheap from Care company, and you can easily implant like he demonstrated. There is no learning curve, and so it's quite easy.
As such, yes, yes.
But having said that, still there can be some residual power. The best what is described is the laser vision correction, that is LASIK or any other, but obviously it cannot be done in hypermetrope.
Yes, sir. I started my journey for hypermetropes actually. So that is the main place. Yes, sir. Yes, sir. Yes.
As you said, open angle, though, so you have contraindication if narrow angles or something. These eyes.
So this is all in my mind because I'm going to put 2 IOLs, so I'm not sure if this IOL is going to make.
That's the logical.
Yeah, and they have 4
question I have.
haptics, so that is in my mind. So that's why I was thinking.
Any literature support whether you have seen any glaucoma, induced glaucoma subsequently?
So no, I haven't seen.
Causing peripheral synechias because those haptics slipping and pushing in. Obviously, iris is little bit to get pushed up.
Elevated, yes. So I haven't observed because I have done gonioscopy again. Because the first is 2 years plus. So I have done gonioscopy as I showed you. These reports are of 2023 end because when I published it in IJO, they wanted the post-operative results as well. So naturally I have a data of the post-operatives also.
Sir, what I feel that the design of this lens is better than the Rayner one. The Rayner one, you got a long haptic actually that sits into the angle, but here there are 4 only, which
So not only 4 haptics, they are very pliable, very, very flexible. As I was tucking them in because you have little space when you're doing a secondary IOL, the space is not much and you really have to be careful it doesn't go in the bag, because later on I had a case where 1 haptic was in the bag and I had a tough time taking it out and putting in the sulcus. So these haptics are very pliable, they are very flexible.
Yeah, Dr. Sudipta, one query.
Yes, sir.
What is going to happen in the long term? The interface changes between the 2 lenses.
Interface?
Yeah.
I'm not sure of that because my data is of 2 years plus, but I had to do one case, I had to do a PCO which developed in the primary IOL, but till now the interlenticular phase is okay.
And what is the space between the 2 lenses, the vault or whatever
Said
you call
to
it?
be 0.2 to 0.4.
So they are not in contact with each
No, sir,
Not
they
at
are
all.
not in contact. They are not in contact. And usually, sir, these cases are myopics because
Yeah,
where we
that
put a
is-
0 power or a negative IOL inside and then we have all these problems.
So for that you measure the white to white also?
Yes,
Just
sir.
like
We
the
do
ICL?
measure the white to white,
Then only-
not only by IOL master, etc., but we also do the digital same way as we do for phakic IOLs.
Okay, right.
Yeah, that means now you said there is a space between 2 IOL.
Yeah.
Now that means practically you are creating a telescopic system. Okay.
Yeah.
So how you calculate the power?
Yes, sir. I know this question is very relevant question, and the power of this lens, sir, what I understand from the toric one, they said it's patented, we are calculating all that, the distance and all that which has been taken, but what I understand is simply transposed. So it's by God's grace. Maybe my learning will continue over the years. Yes, sir.
Yeah, so actually, Sudipta, you showed the care group, and I've implanted quite a lot of the Rayner ones. So they are very, very good IOLs, and they really serve the purpose very well. It was one instance in which, they are not biconvex IOLs. So it's the right side up, and inadvertently it flipped out. So it went in the wrong side. And here, because the AC depth is just about maybe 3 millimeters or so it becomes tough rotating inside or flipping
No,
it
you
inside
can't do
the anterior chamber. So that is one very important thing. However, in these ones with the 4 haptics, the chance of it swiveling over is very
it's
rare.
less. And anyway, sir, with same as phakic IOLs, I usually go halfway and then retract if it's tumbling. So thank you.
Okay. I will invite Usha Ben ma'am and Dr. Bakulesh sir to kindly felicitate Dr. Sudipta.
ये पेन ड्राइव निकाले, पेन ड्राइव निकाले. This is a lifetime picture.
Then I'll go. I'll take the picture.
Sir, you are the person who arranged it.
Sir, मैं मजाक ही ले रही हूँ. I'm never serious. Not a serious person.
Thank you.
नहीं तो शलभ के साथ नहीं तो शलभ में जिंदा रहना. इतना serious करा देते हैं कि वो पागल हो जाए इंसान. हाँ ये अब आ गया. अच्छा मैम.
I will now invite Dr. K.S. Gupta sir to kindly come and show his surgery.
मेरा वीडियो कौन वाला ये वाला ये आपका एक्सेस वाला हाँ बस वही चाहिए बाकी क्या करना बाकी अंत में दिखला देंगे
So, एक मिनट stop कर लो.
हाँ रुके
Dr. K.S. Gupta sir is past president of Bihar Ophthalmological Society and is a very senior phacosurgeon and belongs to Saharsa and also practices in Patna. Sir has always had a very unique way of private practice and all those in Saharsa would agree that जो इनकी सोच थी कि किस तरह से डॉक्टर्स को प्रैक्टिस करना चाहिए, कितना चार्ज करना चाहिए, कितना कम कितना ज़्यादा, बिकॉज प्रॉब्ली हम लोग शायद बहुत अंडर चार्ज करते हैं, पेशेंट्स को समझ में नहीं आता है और मैं एग्री करता हूँ जिस तरह की सर्जरी हम करते हैं फेको सर्जरी और जो लैप्रोस्कोपिक सर्जन है वो तो फिर भी बहुत बड़ा इंसिजन है, बहुत बड़ा इंस्ट्रूमेंटेशन है. वी आर वर्किंग इन सच अ स्मॉल आई with millimeters of difference between the cornea and the lens, and we have to be so precise. But हम लोग बहुत कम चार्ज करते हैं. The laparoscopic surgeon will charge 50,000 for a simple appendix operation and compare that to a phaco. So I think सर की जो सोच थी और सर ने उसको सहरसा में इम्प्लीमेंट भी किया, वो शायद अगर पूरे बिहार में हो तो ज़्यादा अच्छा होगा. बिकॉज हर चीज़ का एक कॉस्ट होता है, मशीन का, फेको मशीन का, माइक्रोस्कोप का, और जैसे जैसे आपकी प्रैक्टिस बढ़ती जाएगी आप उससे भी महंगा इंस्ट्रूमेंट लेंगे, फेको मशीन लेंगे या उससे भी बेहतर बड़ा माइक्रोस्कोप लेंगे. सो वी शुड नॉट अंडर चार्ज. अनफॉर्चुनेटली हम लोग बिहार में हैं, बगल में नेपाल है, वहाँ इतने कम में ऑपरेशन हो जाता है. लोगों को समझ ही में नहीं आता है कि हम लोग इतना क्यों चार्ज करते हैं. अगर हम थोड़ा ज़्यादा भी चार्ज करते हैं वहाँ तो इतना में हो जाता है. तो प्रॉब्ली इनकी सोच जो थी वो एटलीस्ट मैं समझता हूँ, बाकी लोग भी इस चीज़ को समझे और वी शुड ट्राई एंड फॉर्मुलेट चार्जेस विच आर नॉट as low as what we are charging right now. Sir.
सबको मेरी जय श्री आराम जी। ये लेंस देखिए, बिल्कुल वाइट कैटरेक्ट है, इंटुमेसेंट कैटरेक्ट, और इस तरह के कैटरेक्ट में अर्जेंटीनियन फ्लैग साइन होने के पूरे चांसेस हैं। तो मैं अपना यही टेक्निक दिखाना चाहता हूँ। ये एक बार कभी AIUS में भी शायद प्रेजेंट हुआ है, मैं उस सेशन में नहीं था, लेकिन शायद हुआ है। तो हाउ टू अवॉइड अर्जेंटीनियन फ्लैग साइन। Yes, I have made 2 side ports and 2.2 millimeter main port, and the tip is 1.8 millimeter and the sleeve is 2.2 millimeter. Now, before making CCC, before attempting to make any rexes, what I am doing, see, I have gone in, और जो टिप है वो टिप इज फेसिंग डाउन, द ये फेस डाउन, और मैंने फेको मोड 2 में जो क्या बोलते हैं ब्रेक करने वाला मोड होता है उसमें गया हूँ, और मैंने फेको पावर इस्तेमाल कर रहा हूँ। एक बार में नहीं हुआ। ये क्या होता है, नहीं हुआ, फिर मैं ट्राई कर रहा हूँ। देखिए, हो गया, डन। नाउ आई विल मेंटेन द चैम्बर विद HPMC from another side port. You can see I have made a rent. What happens कि जब आप फेको पावर देते हैं तो पहले वो एस्पिरेशन करता है, वो कैप्सूल को पकड़ के अपने तरफ टान लिया, और जैसे ही फेको पावर दिए वो उसको कैप्सूल को ब्रेक कर दिया और अर्जेंटीनियन फ्लैग साइन नहीं होने दिया। और इसके बाद में यूजुअल जो होता है CCC, मैं वो करने जा रहा हूँ। सी, नहीं हो पा रहा, नहीं हो पा रहा तो चैम्बर शैलो है, थोड़ा सा और HPMC देंगे। Then I will continue with capsulorhexis forceps. Of course, the CCC is small, but there is no Argentinian flag sign, and the rest of the procedure, FECO, I need not show. Ultimately, I have put a triphobic ट्राइफोकल IOL। दूसरा वाला वीडियो है, अंत में खाली दिखला देना। ये लास्ट है? नहीं, ये नहीं है। ये जो है विदाउट ट्रिपान ब्लू था। हाँ, अंत में और पीछे ले जाएंगे। नहीं, डाला है वो कैप्सूल एक्सिस छोटा था, वो उधर चला गया। सी नाउ लेंस, you can see the lens and it is in the bag, just doing IA and packing up. You can see this trifocal. This is a triphobic lens from Care Group, and I have implanted this in plenty. I don't remember the figure. I must have implanted more than 200 or 300. Okay, thank you. This is my way of avoiding Argentinian flag sign, and I have till now I have failed in only one case. Only one case.
I will request Dr. Partha Biswas sir to kindly felicitate Dr. K.S. Gupta sir.
डॉक्टर के.एस. गुप्ता सर, एक चीज़ पूछना था सर।
हाँ।
कि कौन सा फिजिक्स इसमें इन्वॉल्व है सर कि आप फेको से रेक्सिस का इनिशिएशन कर रहे हैं सर? आई मीन सर फेको का जो आप कैप्सुलर रेक्सिस का जो इनिशिएशन जो किए शुरू में सर, सो व्हाट इज द फिजिक्स इन्वॉल्व एंड व्हाट इज द डिफरेंस बिटवीन यूजिंग अ फेको पावर टू क्रिएट अ रेक्सिस initiation from that what we do with the cystitome or other.
Once you puncture this lens, you will straightway get Argentinian flag sign. You will not get any time.
So why this is happening, sir? I mean, can it be explained why this is happening, sir?
Because the intralental tension is high. There is liquid matter in the lens, and it is very high, and it bursts open the capsule from here to there.
So what do you mean to say that you do a phaco burn with the phaco tip with the phaco power, number one, and at the same time the aspiration takes care of whatever intralenticular pressure is there, that takes out the cortical matter. So simultaneous there is a phaco burn which creates a hole in the anterior capsule, number one, and simultaneously at the same time it aspirates the cortex, which prevents the agitation.
Which is under pressure, so it doesn't let it to go this way.
Okay, sir. Right.
Sir, this technique was long back described by Dr. Mohan Rajan, puncturexis. And Dr. B.P. Kasav is also doing. Yes. Actually, the concept is the moment you puncture, it takes out some cortex and decreases the intralenticular pressure. That is the reason. But there are so many various ways of handling these intermittent cataract. This is one of those.
Yes.
I tried in one or two, but I felt little difficult, so my way of doing is different.
I must have done more than 100, and I have failed in only one.
Actually, what I feel is that you need a very sharp and a new phaco tip to do this. If you have used the phaco tip multiple times, it becomes blunt. And with that blunt one, it's slightly more difficult to do this.
Shalabh, is it because of the physical pressure of the phaco tip, or is it because of the phaco power, the burn that you create in the capsule?
No,
I think it is because of the phaco burn.
Yes, but still, because you have...
Is it because of the physical forces of the phaco tip?
No, it's not physical.
Right.
But still you need a very sharp and a new phaco tip. Right. Because as sir also said, I have also tried it. And
I've never tried it. I just thought, what?
No, I've also tried it, but I think what I do is that needle puncture and aspiration,
exactly,
which fortunately has worked very well in my hands.
I just have a question for you, Doctor. You said sharp and new. You are using ultrasound energy, so it's nothing to do with like our vitrectomy cutter blunt ho gaya, but it should be, everything should be sharp. It's ultrasound energy. It's always sharp, right?
Yeah,
Because
because I failed, I thought I was using an old Fico tip. That's why, and that's how I try to look at it.
Maybe sound energy which is giving deliver may not be that adequate enough or not efficient enough probably.
Yes,
but
yes.
At
Yes.
frequency we want, probably that you mean. So
Yes, very true. But what I was discussing with Dr. K.S. Gupta sir was that in those cases where I have had a Argentinian flag sign, are those cases which when we do biometry, we must always see the lens thickness. When the cataract is very, the lens thickness is more, it means that it is under pressure. So anything more than 4 or more than 4 millimeters, we should be more careful.
I think you said that there should be new tip all the time. I don't agree with that. अगर ऐसा होता तो डॉक्टर के एस गुप्ता जो कि पैसा इतना पकड़ते हैं, सब में नया नहीं यूज करेंगे.
Now that we have in these intumescent cataracts, it is becoming more and more predictable how it does, so that it does not run out. So the other way is the anterior segment OCT. If you do an ASOCT and if you find there are multiple pockets of fluid, then those are the intumescence that will not will possibly run out. So you have to be extra careful on that. And of course, as Subhash was saying, that there are the taking out of or milking out the anterior chamber fluid, the fluid inside the lenticular capsule is also a done method. But here, Dr. K.S. Gupta's case, there was a slight curve of the punch that he had done. So if the intralenticular pressure had been more, that punch that actually could have run out. But the beauty is that there was enough of suction so that the lenticular fluid was drawn out and it did not run out.
If the vacuum is not controlled in these cases, the risk of zonular dialysis also can be there.
Yeah, I will not agree with that. Why? Because the punch comes first and then the aspiration. If the punch does not occur, then you are right, Deepak, that it can draw out. Okay. But if the punch occurs, then it will be the fluid that will be drawn out. Okay. So it might be a little unpredictable at times, but usually works quite well.
I will request Partho sir to kindly give a memento to Dr. Sudhanshu. He had chaired a session yesterday, but while we were giving the mementos, he had to leave. Thank you very much. This brings us to the end of this session. After this, we have a diabetic retinopathy session with the the All India Physicians Society, which is supposed to start at 1 o'clock. Again, like yesterday, we had a meeting with the pediatricians. So today we have a meeting on diabetic retinopathy with the physicians and the IMA. So we'll take a little break and probably 1 o'clock we will start that.
I use a MVR blade to just cut through, and here it is safe because you know there's a cushion of blood, so unlikely you damage the retina. But as against this other case where vitreous is firmly adherent to the retina and you need to create a cleavage plane, there are various ways. You can use a blade, you can use a cutter, if there is space you can use your MVR blade, or even sometimes scissors as well. And once you get that you are at the right plane, then sometimes things become easier, lifting it up around. But then these are always highly edited videos, so on table you will all struggle, so it doesn't seem to be that easy what you see on the table here. So but what difficulty when you have typically when a diabetic eye is you have combined detachment, vitreous is still firmly adherent but retina is mobile, so you don't have counter traction and you cannot induce PVD. Here is like what you do in a regmatinous RD because vitreous is firmly adherent, so you go clock hour by clock hour, lift that vitreous, cut that area and then move forward, and probably sometimes your light pipe acts as a second instrument to hold the retina back, so that gives you counter traction, but ensure shaft of the light pipe is supporting the retina, not the tip. If you support with the tube, you tear through the retina and it just poke through the retina. So holding the retina back with the light pipe and gently lifting up your with the cutter suction, using it, lift it up and it moves forward, and that's why slowly you go all around 360 degree. And because unless you remove this vitreous, you are not going to get a plane for dissection for your membrane surgery when you start. So coming to membrane surgery, as I said, identify correct plane for dissection is the most important step. Depend whether to start periphery and go towards center, or you start in a center and going to periphery. It depends on how the configuration of detachment, surgeon's expertise and comfort, and you have available instrumentation. So what is more important, what we call as vitreous chysis or second membrane. So what actual age of the membrane you see, that's generally not a membrane. When you have to go beyond that, some glistening tissues you will be seeing here, and as you see here, not this one, but this is a membrane. Unless you remove this tissue, you are not a right plane. Similarly, age you are seeing here, but that is not what is membrane is. A cleavage plane is there. What you are having, another translucent membrane, you see shining glistening membrane here. Unless you remove that one, then only will be at a right plane. Most of the time you will try go directly here, then you know you are at a wrong plane. You will end up creating iatrogenic problem. Sometimes you create a lot of bleeding also during surgery. Yes, there are various ways. You can segmentation, you cut across the membrane and make a small island, or you have a delamination where your scissors are parallel to the retina. So you go cut those nails and lift the membrane over what you call as carpet rolling. But actually, in a true sense, when a real life scenario you work with these eyes, you do knowing unknowingly combination of everything. Partly you desegment, partly you delaminate, lift the membrane at one side, and it's always a combination of everything, not just one single technique you use during surgery. Yes, delamination when you periphery to center, when you talk about most of the cases, what we do is start at the periphery, work our way towards the center. Membranes are basically avascular periphery, so the chances of bleeding is less, and once you clear the periphery, probably better chances of getting cleavage plane. But sometimes what happens, membranes are so thick, there is no PVD, they are firmly adherent, there is no way you can get a cleavage plane around. So basically you start on the disc, sometime around the macular area, over the arcade there is a translucent membrane, the gap. You use that gap. Basically you have to be opportunistic wherever you want, and particularly when you are doing the combined detachment where retina is mobile, there is no counter traction, so disc act as a fulcrum, and when you dissect away from the disc, and that helps you to give a add-on counter traction, and generally we prefer scissor there, go and each segment, each attachment, snipping it off and go towards the periphery. So peripheral retina being again thinner, the chances of creating iatrogenic is much higher there. So if you start over century, you minimize that risk. But obviously posterior pole is always more vascular, and there is sometimes increased risk of creating increased bleeding in this. So changing trends we have now is we are using more and more MIVS, rather most of the cases now. We are having a new cutters with a high speed bevel tip, so have accessible to the approach closer. You have wide angle visualization, better illumination, and also we are using anti-major, so we are going, so basically we are able to manage more and more complicated cases. So what is port optimization means? So basically, port is placed near to the end of the probe, so which allows you to work closer to the retina and transform this probe into the multifunction instrument. We have a 20K instrument, and particularly what you mean by port optimization, as you see here, the port is so close and you have a bevel tip now. So this same cutter, you can use something like a spatula to lift the membrane here, so use the suction as a grease, or you can use as a pick forceps here, and again lift and cut, lift and cup. So probably you can eliminate the use of scissors here. This is another one just to compare, showing two similar videos. What one we do is using a scissor to each tiny attachment you cut it off, and similarly what you do with a newer cutter now, because of port optimization, see exactly similar steps going on here. Cutter is being used as a scissor, but what you do here is reduce the cutting speed. These are not like a 10,000, 20,000. So reduce the cutting and use as a shave mode. So precisely you cut each and every single attachment just like you are, as if you are using a cutter as a mechanical scissor, and that helps you to manage these cases much better way. So wide angle visualization system definitely give a panoramic view and better view during fluid air exchange. And this is again video similarly which I showed, having a small pupil, both eyes, but see excellent view right up to the periphery when you are handling these cases. So surgeon's comfort and basically orientation is far better. Again, this is one more case comparison. When you use a Lander's lens, what you see with a this is segmentation as against when you use a resight, which is most commonly used technique. So periphery is very well visualized even with through smaller pupil. So illumination sources, you have multiple sources now, and with these illumination sources and various filters, you reduce the retinal phototoxicity as well. And because you have now chandeliers, you have a multifunction instrument. This is light with the illumination, with a infusion, and then here is a fourth port. So you have, in a true sense, now we are doing a bimanual surgery with a wide angle view and wide illumination, excellent visualization for your surgery while operating, not really holding the light pipe in one hand. So fluid proliferation, obviously we need to use anti-VEGF to minimize the bleeding during the surgery. And what actually anti-VEGF does is reduce the vascularity, and that way probably makes surgery technically easier. And somehow we all feel maybe because of bleeding is less, so fibrovascular proliferation also readily separates from the retina when you are given anti-VEGF. So when you have less intraoperative bleeding, you reduce endodiathermy, so naturally post-op inflammation also is reduced. And because visualization is good, so your overall surgical time also is reduced. Fewer fluid like tool exchanges, so sclerotomy related complications also are reduced. And because of more complete fibrovascular tissue removal, so we have reduced the risk of reproliferation, and obvious recurrent post-op hemorrhages also is reduced in overall better functional rate. So it's critical to use a window when you're giving intravitreal injection. Generally we prefer somewhere between 3 to 7 days, because if you anything more than 2 weeks, there is a risk of reproliferation, and sometimes they come as a rebound and land up severe bleeding. So ensure that patient is general condition is stabilized, fitness is given, your anesthetist and physician, and then you inject and then plan the surgery accordingly. And these are two cases, two eyes of a same patient, young girl with a anti-VEGF injection and massive proliferation, but looks almost everything is avascular now. Surgery went off smooth, almost is a bloodless surgery, and practically no vessels are seen. And this is post-op picture. This is a 2 months photograph, but the girl is still maintaining 6/12, 6/9 vision in right and left eye over now 3 years follow-up, and she is doing her final MBBS this year. And this is another case showing pre-Avastin picture, vascularity, and when you give post-Avastin, this is what vascularity is reduced, post-operative picture of this patient and other eye of the same patient. If you need some additional procedure sometime, add on buccal or retinotomy if you have a residual traction left over. If you create a break, obviously you need to do fluid air exchange, add laser and plan-retinal photocoagulation and tamponade if there is a break. So to conclude, tractional detachment and combined retinal detachments are commonest indication for vitrectomy in PDR. Extramacular TRD can be safely observed because overall what is shown that it's very slowly progressive, and in fovea notch involved even it takes up to 3 years to reach the macula. Although various techniques are described, generally the selected one is a combination of all. MIVS allows vitrector to be used not only as a cutter but also as a forceps, scissors or a pick, reducing the need for ancillary instrumentation and making surgery more safer and less. 6. Bimanual surgery facilitates more aggressive membrane dissection and hence make difficult cases amenable to the surgery. Pre-op use of anti-VEGF helps to minimize intra-op complications and to achieve more complete membrane removal, leading to overall better anatomical success, but however, final visual outcome always depend on our macular status, and particularly this case, though everything went off well, large exudate under the fovea, vision was we could achieve only 1 minute. So thank you very much for patient hearing, and once again let me congratulate Dr. Chalab and Pallavi for this Silver Jubilee celebration and good wishes for many more to come. Thank you once again.
Thank you very much, sir. मुजफ्फरपुर के हमारे बहुत सीनियर टीचर SKMCH में बहुत साल प्रोफेसर रहे और HOD रहे और आशीर्वाद देने हमें आज यहाँ आए हैं डॉक्टर बीबी ठाकुर सर। तो आपका बहुत बहुत स्वागत है सर, और हम बहुत खुश हैं आपको यहाँ देख करके। तो मैं डॉक्टर पल्लवी से अनुरोध करूँगा कि एक फूल का गुलदस्ता देके उन्हें उनका स्वागत करें। And I also welcome Dr. Sudhir, Secretary of IMA. लीजिए पल्लवी, आइए सर। मैं डॉक्टर सुधीर सर से अनुरोध करूंगा कि कृपया डायस पे बैठे। चल रहा है Zoom link? हाँ चालू है सर।
Pramod sir, one question I just wanted to ask, like, since now the use of bands, buckles and all have gone down drastically, but if we see like there are a lot of peripheral membranes, still do you suggest that we should use a encerclage band in these cases, or should we just go ahead with vitrectomy directly?
I still use a band if necessary. I still use particularly, and even not only band, sometimes I use segmental buccal also. The reason being particularly phakic eyes. So you do a clean job, you have peripheral residual traction.
Yeah.
So if you try to go for it, there is a high risk of creating iatrogenic break because retina is thin.
Yes.
And sometimes you will end up touching lens also.
Yes. Yes.
So I feel sometimes it's better leave that residual traction, support it, rather than going inside and cutting. So then one break you create an entire surgery, you compromise everything.
Yeah.
So rather than and if you relieve the traction, later on you have recurrent bleed and reproliferation.
Yeah.
So what I do still, sometimes with encircling band or even that segment, and if I cannot reduce the traction or leaving it, I doubt, I just put a segmental buccal, I still do that. But selected cases, most of the cases we can manage because view is very good. But I do not hesitate having, and touch wood, till now I have not landed anything what we talk about anterior segment ischemia and all those things, because see, unless you really constrict that, you don't have to worry about.
Okay, sir. And another thing, if if the retina is unlasered pre-operatively, so would you suggest to laser the unlasered areas first before doing the surgery, or would you just inject anti-VEGF and go for the surgery?
There are two ways of looking at it. So doing laser pre-surgery is definitely much easier, but if you do laser and taking within a week or so, then the problem is now you are dealing with the edematous retina, and if there is no PVD, while inducing PVD, there is a high risk of creating iatrogenic break. Okay, so if your surgery is getting delayed because of some reason patient is not fit because of systemic parameters, probably I would do laser off, at least that part. But only thing is you have to ensure you are lasering away from the proliphage, at least 1 to 2 days the area. Otherwise, when these laser contracts, there are quite a few patients, you do laser and he comes with a combined detachment. So do laser if patient is getting delayed. But doing laser and immediately taking, because you are not taking away that vasculogenesis factor, no added advantage if you are taking within a week or two. So then might as well do on the table, finish up good membrane dissection and do laser on the table.
Okay.
So basically you can look at both ways.
Thank you. Thank you. Next, I would like to invite Dr. A.K. Das, sir. He's the chairman of Bihar API, to talk on diabetic mellitus control, the current perspective.
Thank you so much, sir. Thank you. Yes, sir.
Hello. Thank you very much for inviting a physician on a ophthalmological platform. I must congratulate Dr. Shalabh Sinha and Dr. Pallavi ma'am for this Nayandeep. Congratulations for 50 years. It's a long journey which has been made very easy, and it's going to live for another 100 years. We have next 100 years because we are seeing two generations coming in front of us. Right, sir. I must welcome our professor and guide, Dr. Professor B.B. Thakur, sir, amidst the august gathering. And today I have been asked to delve on the recent trends in type 2 diabetes mellitus. Well, diabetes is a universal phenomena and it is going to take toll on everybody. And it is one of the leading non-communicable disease across the globe, and it's rising at a very fast pace. We always think, what is the current status of diabetes in this country? And the ICMR has just come up with the recent update on the statistics of diabetes with the ICMR India 2 study, and it shows a very pathetic picture as far as diabetes is concerned. You can see the prevalence rate across different states, and in the urban you can see the entire country red, on the rural some part red, and this is the status of diabetes. And if you compare it with pre-diabetes, again almost half of the country is red. So if we combine both of them, the entire country is red. So India is bleeding red of diabetes. And just see the current status of all the non-communicable diseases, and of all the diabetes stands at a whopping 101 million population suffering from diabetes. India is one of the biggest or largest country having diabetes population in one country, and Bihar has a prevalence of almost 10.5% in the urban settings. Now I still say that if we go on to the rural population, the status of 3.5, which is shown in this study, is going to increase if you do it correctly. But what we have come to understand that regarding diabetes, there is no longer male to female difference. So we see diabetes sees all sexes equally. So it afflicts the females and the males equally. If done correctly, the rural and the urban difference is also going to melt away. It's no longer a rich man's disease. So everyone is going to get afflicted. So irrespective of you being a BPL card holder, you are still going to be at the similar risk of diabetes as a person who is flying. If by all resources we stop the current epidemic of diabetes, so in 2007, this is the old slide, if you stop progression of diabetes in 2007, even if there is no increase, the number of people living with diabetes is still going to increase. Despite all our efforts, the friction is going to sustain the diabetes prevalence for the another 2015. So diabetes is a disease here to stay, and we need to understand that why it is so. So these are some of the known risk factors for type 2 diabetes, and despite all our efforts, these risk factors are not decreasing. And diabetes is a conundrum of diseases. So ophthalmologists are worried about diabetes, so are cardiologists, the nephrologists, the neurologists, the physicians, and all those persons who are in any way related to health sector are worried about the status of affairs with diabetes, because it's going to involve everyone. Heart disease, 70% of people with diabetes die of heart attack or stroke. 10 to 20% of people will die of kidney disease. 2% of people are going to go blind because of diabetes. And 50% of people are going to get affected with neuropathies. So it's going to affect all organs, and we all are going to get engaged in the care of diabetes. So we need to understand some basic things and what is the current status of affairs as far as management is concerned, because we are seeing a large number of medicines which have been discovered now and are being used rampantly. So every sector of health needs to understand what is the current status of affair as far as diabetes management is concerned. So how do you diagnose diabetes? A fasting plasma sugar of more than or equal to 126 milligram per deciliter up 2 hours postprandial on an OGT more than 200 milligram, HbA1c of 6.5, or symptoms and a random sugar of more than 200 milligram per deciliter. This is diagnostic criteria, any one of them. Pre-diabetes is slightly less, and we have seen large improvements in the diagnostic system of diabetes. From urine sugar, from plasma sugar, we have gone on to HbA1c, and now we have gone on to continuous monitoring of diabetes. This audience is not meant for these intricacies, but I'll let you know that diabetes technology is taking great leaps ahead in the not only diagnosis but also in the management of type 2 diabetes. What is the target? So target is fasting, target is postprandial, target is HbA1c, targets are glycemic variability and the latest time in range, which is TIR. This is what should be the control? An HbA1c target should be less than 7, a preprandial between 80 to 130, a postprandial less than 180 milligram per deciliter. This is the target which we should try to achieve. And how do we achieve that? So before going on to the therapeutics per se, we must understand that what causes diabetes. And Di Fronzo came out with a interesting concept of ominous octet. He says that there are 8 organs involved in diabetes causation, rather than things have moved ahead and we have a dirty dozen now. But for this slide, let me focus that hyperglycemia can be caused because of some effect on the brain, causing neurotransmitter dysfunction, hepatic glucose output production at the liver, at the pancreas, the islet cell disturbances, decreased insulin secretion at the intestine, incretins may be dysfunctional, at the adipocytes there would be increased lipolysis, at the kidneys there would be impaired glucose absorption, at the muscle there would be decreased uptake. So all organs, you think of only pancreas causing diabetes. No, it's not only pancreas it's causing diabetes, it's causing the entire body is at fault. I can name only 8 out of them which is causing diabetes. And based on these ominous octet, we have discovered drugs which can act on alpha cells, drugs which can act on beta cells, drugs which can act on liver, drugs which can act on the incretins, drugs which can act on the brain, drugs which can act on the kidneys. So multiple drugs have been developed based on these ominous octets, and based on that we have come out with different diagnostic algorithms, when to use, what to use, when not to use, how to combine. So these are something which is coming of late, and now things have moved ahead. So the weapons of war against diabetes can be basically classified as injectable agents and oral agents. You think of insulin as the only injectable agent available. Now we have the GLP-1 receptor agonists, the glucagon-like peptide receptor agonists, which are injectable agents, powerful agents. We have amylin mimetics pramlintide, which has come of late as an injectable agent. So we have 3 injectable agents and multiple oral agents which you all must be aware of: the metformin, the sulfonylureas, the SGLT2 inhibitors, the DPP4, the thiazolidinediones, the alpha glucosidase inhibitors, and so much and so forth. So these are some of the weapons of war for use against a pandemic called diabetes. And we have 2 general principles. You can just add on one drug after the other, or we can start 2 drugs at a faster pace. So earlier and appropriate intervention may improve patients' chance of reaching goal. So you need to be aggressive. Why aggressive? Because if you be aggressive, you can put a very good impact on the patient's metabolic system. The body understands this metabolic memory, and it has a good legacy effect. So if you have a good control over good period of time, your chance of developing complications, your chance of going to an ophthalmologist's chamber is less. So a metabolic memory is what we target for. A good glycemic legacy is what we target for. We have developed 2 blockbusters as far as anti-diabetics are concerned in 2019, and these blockbusters are still ruling the charts. These are incretin mimetics and the SGLT2 inhibitors. So what is an incretin? Incretin are GI hormones which are released whenever you take food, and they stimulate insulin release. So GLP-1 and GIP are 2 incretins. GIP has been later on developed. Now we have a drug which has a combination of GLP and GIP, and GLP is going to signal the intestinal hormones to release insulin, and therefore it's going to decrease the glucose level. So this GLP or the incretin is going to control sugar based on your oral intake. So whenever you take food, the glucose is going to go down because of these effects. So it is a very good drug. And incretin based therapies, we have 2 different class, which is GLP-1 receptor agonists, which is exenatide, liraglutide, lixisenatide, and we have dulaglutide and other agents, and we have oral agents which are the sitagliptin, saxagliptin, vildagliptin, linagliptin. So these prescriptions might be coming to every doctor's chamber now. So you must be aware that these are incretins and they are fairly good agents. GLP-1 receptors are injectables. They can be taken once weekly only. So once weekly injection can lead to have a huge impact on diabetes, not only diabetes control, but because they are incretin mimetics, they decrease the appetite, and by decreasing appetite, by having an effect on the satiety center, they go on to cause weight loss also. So these are agents which are approved for weight loss, not only from diabetes control but also weight loss, and these have good impact on heart, kidneys, so they have a cardio-renal advantages. So these are some of the new things which we have come up with. And then we have the SGLT2 inhibitors with sodium glucose co-transporter 2 inhibitors, which act on the proximal convoluted tubule of the kidneys and prevent glucose reabsorption. So if there is no glucose reabsorption, the excess glucose goes out of the system through urine. So you start urinating sugars and thereby decrease the blood sugar. So it sounds very simple that glucose is going out. So what is the metabolic impact of that? These are some of the SGLT2 inhibitors available across the world, and they not only decrease sugars, but they have good metabolic impact. They have impact on the kidneys. They have been found to decrease, in fact, slow the onset of kidney disease. So even if you have a kidney disease because of diabetes, the progression of kidney disease slows down if you use SGLT2 inhibitors. If you have heart disease, the progression of heart disease slow down. The chances of heart failure decreases. If you have a liver disease like a NASH, what we now call as MAFLD or MASLD, because you are losing weight, because it has a metabolic impact, your chances of development of NASH to cirrhosis goes down. So these are some of the tremendous advantages which is going beyond diabetes control. We developed these drugs for diabetes control. Now they are not merely diabetes drug control, they are metabolic drugs. The GLP-1 receptor agonists and the SGLT2 inhibitors, in fact the incretin mimetics, are drugs of future. So if you see the building of diabetes, the architecture depends on diet, the pillars are exercise, the drugs, education of the patient, and a coordination. The fifth pillar is coordination among the four. A doctor who understands the importance of this, the patient who is able to understand these things and coordinate everything. So the 5 pillars of diabetes management are diet, exercise, drugs, education, and coordination. Now let's come on to the guidelines. The guideline says don't treat patient as a small window. He is having a diabetes. Think about not only his other metabolic diseases, but think this patient as an individual. A person who may be having no person to take care of at home. A person who would be very fragile, a frail patient, a person who would be extremely busy because of his job. So you need to understand the patient in totality before prescribing any agent. Whether the patient is fit for an injectable agent, whether the patient is fit for an oral agent, whether the patient can take 2 drugs at a time, whether the patient is able to read what is written on the injection. So these are some of the things these are very small things. How much is he motivated? So you need to see the patient in totality before prescribing a drug. So the guidelines say that take a wagon wheel of whole life of that patient and understand and then prescribe. Of course, these are some of the ways by physical examination, history taking, all these things have to be taken care of. And what I was trying to tell is what 2015 ADA guidelines have already depicted, that individualize your patient. A patient who might be having a disease of long duration need not be very stringently controlled. A patient who is expected to live less, it need not to be stringently controlled. A patient who might be having kidney disease, heart disease, liver disease, he's on dialysis, so you don't need to be very stringent with HbA1c of 7. Established vascular complications. So you have to individualize each and every patient before prescribing. And this is the latest algorithm of diabetes management. Sounds very clumsy, but I'll make it easy for you. Now there are 2 parts to this. So the first part is glycemic control. The left side says the glycemic control needs to be taken care of. Yes, that's good. So you need to choose a glycemic agent of variable severity. Now if the patient is having very poor control, you need to use a high or a very high efficacious agent for glucose lowering. And the very high agents for glucose lowering, very high efficacious glucose lowering agents are dulaglutide in high dose, semaglutide for tirzepatide, insulin, and combination of these agents. Now if the patient is not at a very high risk or very high, you need to use moderately drugs, then you can use oral drugs like SGLT2 inhibitors, sulfonylureas, metformin, thiazolidine, diazone, DPP-4s. So this is one part. The other part says the weight control is a major contributor of diabetes. So you need to control your weight. So the agents which have been established to cause weight loss needs to be prescribed in patients who are diabetic as well as obese. So these agents have been semaglutide, which is a GLP-1, tirzepatide, which is a combination of GLP and GIP, dulaglutide and liraglutide. And you also have drugs which are neutral, like metformin and DPP-4 inhibitors. And there are drugs which can increase weight also, like pioglitazone and sulfonylureas. So you need to understand what class of agents are you going to use, taking into consideration the weight of that patient. This is one part. The other part is that if the patient is having complications, atherosclerotic vascular disease, like a heart attack, like a stroke, like patient having anginas, patient having stents, you need to use agents which can prevent heart diseases, and these agents are GLP-1 and SGLT2 inhibitors. And if the patient is having heart failure, use agents which have been proven to decrease heart failure, and that is SGLT2 inhibitors again. If the patient is having kidney disease, use SGLT2 inhibitors before the other drugs. So this is some of the basic algorithms of management, and here comes the use of insulin. I am not going into details of this, but I must tell you that every line of this guidelines is very important. If you are interested, we can talk in after. So the target is glycemic management, blood pressure management, lipid management, agents to decrease cardiovascular and kidney benefits. I'm sorry, this is an ophthalmological meeting. So I would be incomplete if I do not talk of diabetic retinopathy. All patients who have been diagnosed with type 2 diabetes need to be screened for diabetic retinopathy at the very outset. At the point of diagnosis, they need to be screened for diabetic retinopathy. If there is no evidence of retinopathy for that particular individual, you can increase the duration of screening, but screening for retinopathy at the very outset is a must. Now, one very important thing is that if a young lady comes to you with diabetes, counsel this patient for pregnancy, because pregnancy has been found to deteriorate retinopathies. So screen all diabetic childbearing potential patients who are planning pregnancy or who are pregnant on the risk of development and or progression of diabetic retinopathy. Do a retinopathy screening before pregnancy in the first trimester and should be monitored every trimester and 1 year postpartum as indicated by degree of retinopathy. So treatment, I am a very novice to talk on the treatment. We have experts to talk on the treatment of diabetic retinopathy. I'll just skip those slides. As far as drugs are concerned, drugs have been found to cause diabetic papillopathy, because if you suddenly bring down the sugars very fastly, there is a chance of papillopathy developing. So you need to be very sure about the speed of decreasing blood sugars. If you decrease it suddenly, you are going to have the chances of diabetic papillopathy. As far as drugs are concerned, metformin is huge potential. It decreases the risk of age-related macular degeneration, decreases the risk of primary open angle glaucoma, and it decreases the risk of development of diabetic retinopathy, but also has the disadvantage of causing dry eyes and increases the risk of angle closure glaucoma. So you need to understand before prescribing. Now we talk very high of GLP-1 receptor agonist. I must tell you that GLP-1 receptor agonist as well as thiazolidinediones have the chances of causing macular edema. So you need to be careful about using these agents and talk to your ophthalmological friends every time you prescribe thiazolidinediones on GLP-1 receptor. Sulfonylureas have been used for pretty long time, but it can cause crystalline changes, lens changes, refractory error shifts, accommodative insufficiencies, scotomas, and visual lofts due to optic neuropathy. So this is all about diabetic retinopathy, a diabetes management updated version. Thank you very much for your kind attention.
थैंक यू डॉक्टर ए के दास. पोडियम थोड़ा और शिफ्ट कर दीजिए, एक्सीडेंटली कोई गिर सकता है. ही इज़ अ वेरी बिजी प्रैक्टिशनर इन मुजफ्फरपुर, seeing mainly diabetic patients, happened to be my junior in Patna Medical College, full of gold medals in all 4 years, very meritorious student. ऐसा बहुत कम होता है कि एकेडमिकली बहुत एक्सीलेंट करने के बाद प्रैक्टिस भी उतनी अच्छी हो, बट ये कॉम्बिनेशन है इनका. तो थैंक यू सो मच फॉर योर टॉक, एंड आई वुड लाइक टू प्रेजेंट अ मेमेंटो फॉर द स्पीकर डॉक्टर ए के दास बाय आवर चीफ गेस्ट डॉक्टर पार्था विश्वास सर. And the next topic is going to present by Dr. Partha sir only. He is Medical Director, Tri Netralaya, Kolkata, and Vice President of All India Ophthalmological Society. So, उनका presentation. Another speaker who couldn't join us because of some emergency is online with us, Dr. Raja Narayan, who is Network Director of Human Sources and Anant Bajaj Retina Institute and Director, Suven Clinical Research Center, LV Prasad Eye Hospital, Hyderabad, and Adjunct Professor of Ophthalmology at the University of Rochester, New York. Welcome you, sir, and we are missing you here.
I can't thank Shalab and Pallavi more than my words can say, but it's really been a pleasure and a very packed program for these 2 days. Diabetic eye disease and holding hand in hand, that's something that we need to realize, we need to understand. And Dr. Das's wonderful talk about the ins and outs of diabetes and how retinopathy is very much related. And all that we are concerned, sir, is retinopathy. We are not concerned how diabetes prevails, but that is actually the basic concern for every one of us. So the burden is huge, huge, huge. And the burden of diabetes, especially in these states, is like Uttarakhand, Punjab, Haryana, Delhi, Maharashtra, Karnataka, and Puducherry, Tamil Nadu is in the red, means greater than 10% of the population, and that's a huge number, huge figure. But even more is the bigger struggle is because of the pre-diabetic population in these states of Rajasthan, Madhya Pradesh, Himachal Pradesh, Delhi again, West Bengal in the red, and Kerala. Bihar, Jharkhand, not in the red. So this is important and we need to take cognizance of this fact, and it is very, very important that we understand these figures very well. So 463 million persons with diabetes all in the world, and 700 million diabetics by the year 2045. Diabetic population on the rise and pre-diabetics on the rise. And these pre-diabetics are going to become diabetics in the next few years. India is the second highest number of diabetics in the world, followed by China. And diabetes spares none. But let's concentrate on the eye for the moment. So if we see what it entails us with a total population of 140 million, so 21 million adults greater than 40 years have vision impairment due to diabetes mellitus, and 2.4 million are blind. So this is a huge figure, and we have to take great efforts so that this does not increase, it mitigates. The duration is a risk factor of diabetes, and people with 5 to 9 years of diabetes had a 2.4 times than greater than 10 years of diabetes, which had 4.8 times higher odds of having diabetic retinopathy. Poor glycemic control, odds were 1.5 times. Insulin treatment, odds 2.6 times. And if you look at this very important slide, which tells us that laser photocoagulation, sight-threatening retinopathy is definitely there, and the prevalence of blindness among diabetics was 2.1. But most important is 90% of these people had never undergone a fundus examination, which is something that definitely needs to change. And with this in mind, at the All India Ophthalmological Society, when I was chairperson of the ARC, we had a study of many of these states, and we'll just tell you about the Fixing the Missing Link prevalence data from West Bengal. And this it was. So Mild NPDR was 11.2%, moderate NPDR was 8.24%, and severe NPDR 0.77%. PDR was in the range of 1.3%. And it varied across the states of the country. We had different numbers for Chhattisgarh and Madhya Pradesh. And in the meta-analysis, we also find the same things. But here again, this is a very important slide. And there was a screening of 6,000 type 2 diabetic patients retrospectively who were evaluated. And the awareness level, can you believe it? 63% were unaware that diabetes affects retina. And that's a very, very stark figure. And this is where we need the physician's help to tell patients that you have diabetes. It might affect your eye and the kidney as well. So take opinion from ophthalmologist as well as the nephrologist. So this again is a spectrum, the SPEED study, which shows that older age, lower education, unemployment are risk factors of diabetes and retinopathy. What happens, we all know very well, VEGF is the culprit, and this is the main culprit, and culprit number 1, 2, and 3. Changes from mild NPDR to moderate NPDR will happen if HbA1c is 7% in about 6 years' time, 8% of HbA1c, and it is 5.4 years' time. So why are we so concerned? We are concerned because it's not for the NPDR, but the state of PDR that takes on and ensues with the poor glycemic control. And the blinding complications, which already Dr. Pramod Bhinde alluded to, vitreous hemorrhage, neovascular glaucoma, and tractional RD, are all blinding complications. So when to screen, and Dr. Das has already alluded to, but we have some data. So no diabetic retinopathy within 1 year, and the follow-up should be 1 to 2 years. Every year if it is NPDR, every 6 months if it is moderate NPDR, every 3 months if it is severe NPDR, every 3 months with PDR, diabetic macular edema every year, non-center involving diabetic macular edema every 3 months, and center involving every 1 to 2 months. So when to ask for an ophthalmological examination, known diabetes on treatment, a single record of RBS greater than 200, HbA1c greater than 6.5, gestational diabetes when first notified, and pre-existing diabetic retinopathy, prolonged duration of diabetes. Now again, these are important aspects that we need to understand. So how do we intervene? We all know this. The focal and grid laser photocoagulation when required, anti-VEGF treatment, and surgery whenever it is required. Diabetic macular edema is very important, and the choice for the center involving and the non-center involving diabetic macular edema is also so important. Now look at this leaking microaneurysm and hard exudates not involving the fovea, and after focal laser photocoagulation and good diabetic control, this was what it was. The struggle is real, and we need to put in not only multiple anti-VEGF but at times even steroid injections. So these are important things that we need to do. And in conclusion, so the diabetic retinopathy is a microvascular complication of diabetic mellitus. Early diabetic retinopathy difficult to detect without timely screening by an ophthalmologist. Early diabetic retinopathy can be managed with topical NSAIDs or intravitreal anti-VEGF. Chronic diabetic retinopathy responds very poorly and needs surgery for visual gains, which might be very little. The physician has a very, very important role in recognizing the diabetic patient and referring the patient to the ophthalmologist for timely intervention. So eye examination, 5 years of detection, type 1 diabetes, type 2 diabetes, eye examination as soon as detected. The gestational diabetic mellitus, eye examination within the first trimester, and Dr. Das has already alluded to it, and all patients with family history of diabetic mellitus. So it's a hand-in-hand project. Let's defeat diabetes together. Thank you very much.
Hello.
Thank you, Partha sir, for the exhaustive coverage of the topic.
I will request Partha sir to kindly give a memento to our senior Dr. Baby Thakur sir.
I would request Dr. Partha Vishwas to present a memento to our learned council for this session, because you have to leave for airport. So we are taking this time. इको कम करो, बहुत इको है. म्यूजिक कल था. इको बेस बढ़ाइए. Pramod, Dr. Pramod, please join us. Dr. Love, I invite my Dr. Usha, all invited faculty to join us for this photograph. Ma'am is from Ahmedabad. Yes. खाना खा रहे हैं. दिलवाएंगे आप लोग को, दिलवाएंगे. पहले ही बोल दिया शिवानी को. सर खाना खाने वाले लोग तो आप खाना खाइए.
तो उनको कनेक्ट करेंगे कनेक्टेड है वो. यहाँ से नहीं होगा, उधर से ही है. Next we are going to have a talk on diabetic retinopathy, role of imaging, lasers and anti-VEGF by Dr. Rajan Narayanan sir.
Very much.
Sir is online, so
yeah, can you hear me? Am I audible? Am I audible?
Dr. Raj Narayan sir, can you hear us? You're muted. Can you hear us, sir?
I can hear you. I can hear you. Can you hear me?
Yes, sir. Yes, sir. Please carry on.
But I am not able to share my screen. You have to make me host to enable screen sharing. Then I will be able to make my presentation. I hope I am audible.
So you can share your screen.
And I should be able to share the screen now.
Yes, sir. We can see your screen.
Thank you very much for the kind invitation to share in this joyous occasion of the Golden Jubilee of Nayandeep Netralaya. I am sorry that I am not able to be there physically, because as you can see in my first slide, it was our 37th anniversary yesterday and we had programs running till late evening, and that's why I am unable to join there. But once again, congratulations to everyone there. My talk is on imaging lasers and anti-VEGF and diabetic retinopathy. And this is a photo I got today morning. I saw a very lovely photograph. I'm not saying that they are anti-VEGF, laser and imaging, but a combination of that probably. They are masters in diabetic retinopathy as well. So if you look at the overall imaging that is required in diabetic retinopathy, fluorescein angiography is something which is not commonly performed, it's not routinely indicated. Fluorescein angiography has indications where you have suspicion of ocular ischemia, where there is a delayed arm retina time. I think my slide is moving slow over there. Yes, now I see my slide there on angiography. So either ocular ischemia where there is a delay in the arm retina time, or if you are looking for suspected neovascularization and you are not sure, you can do an angiography. And you can also check for the foveal avascular zone, which typically nowadays we do with OCT angiography as well. So in this case, as you can see, there is neovascularization infranasal to the disc as well as superotemporal, which can be confirmed by fluorescein angiography. Now, the most important or common investigation which we perform is OCT, optical coherence tomography, and there most of us look for that black spot inside retina, which we call as edema, but that edema is probably the single most determinant whether you should go ahead with injection or not. Obviously, if there is no edema, you don't give the injection. But if there is edema, you probably will decide on the injection, but there are various other biomarkers which can be used to predict whether this patient will improve, not improve, or you may have to switch to other agents. So those can be determined by the OCT. And there are different markers which are looked at, like high reflective dots, maybe steroids may be useful in them. Intraretinal cystic hyperreflective material, that is, you have a cyst, but instead of black, it is more white. There are white dots within the cyst. So those are poor prognostic markers. The other poor prognostic markers are disruption of the photoreceptors, ellipsoid zone, external limiting membrane, and drill. If drill suggests ischemia of the inner layers, so even if you treat these patients, the improvement will be less. But you still have to treat these patients if they have edema. Now, this is a big dilemma for patients as well as many medical retina specialists, that if the vision is not improving, you think that you should not treat. But the problem is, if you don't treat, the patients continue to lose further vision. 6/9 will become 6/12, 6/12 will become 6/18, and so on, and become counting figures. So you have to tell the patient that to maintain their eyesight, they will still need injection, even if there is no improvement after treatment. And then you have to look for vitreoretinal interface abnormalities like epiretinal membrane or vitreomacular traction, where vitrectomy is the treatment of choice. Now, OCT angiography is something which is now very commonly available, commonly being performed. You can look at foveal avascular zone in these patients, but it's much more difficult to interpret. Unlike OCT, where it's just you look at the scan and you will be able to make an interpretation. Here, artifacts can be common. You may have to sit with the machine and make sure that the segmentation is all and see that actually what is there is correct. Now, we also have wide angle OCT angiography. Apart from the fovea, you can look at the wide angle. You can look at this case where there is progression of capillary non-perfusion. You see in the lower panel, it is wide angle octa, and you see those capillary non-perfusion areas inferiorly as well as superiorly. They are increasing over time, and you also see these neovascular tufts coming up on wide angle OCT angiography as well. So that completes the part on imaging. Coming to anti-VEGF, we all know there are so many anti-VEGF available. We can have a debate on that for a full session. The time is not available at this time for this talk, but I've just listed what are the different anti-VEGF agents available, starting from Avastin to the other drugs like Eccentrix or Lucentis, Eylea, Paginax, and now recently we have Vabysmo. But what do we do with these injections? What do we tell the patient? If a patient of diabetic macular edema comes, and there are numerous studies which help us to communicate to the patient, to tell them what is going to happen if we treat and what is going to happen if we don't treat them. So if patients are treated with these anti-VEGF injections regularly and at 5 years follow-up, these patients can have up to 2 lines improvement. That is, someone who had 624 vision can have 612 vision, or someone who had 660 can have 618 vision, 2 lines. Okay. Now there is a catch here. Now 2 lines happens in general. The improvement is seen if the vision at presentation is less than 6 by 12 or so. So it's very difficult to have a patient improving from 6 by 12 to 6 by 9. But it is easier for a patient to improve from 6 by 36 to 6 by 18. So less patient at baseline, more is the improvement. Better vision at baseline, less will be the improvement. And what are the different anti-VEGFs? How do they compare? We have these DRCR network protocols which are there, which help us. Eylea, Lucentis, Avastin. Eylea is the best, has the maximum gain in vision, has the maximum drying effect of macular edema. Avastin has the least gain in vision, has the least drying effect, and Lucentis is somewhere in between. And as I mentioned, around 612, 615 vision, if the patient has vision better than 6 by 12, all of them are similar. Avastin, Lucentis, Eylea, maybe even Paginax or Vabysmo, we don't have that data at this time. But what about retreatment? You have to be strict for the first 6 months. Never ever tell the patient कि ये आपका 3 महीने का बीमारी है या 3 इंजेक्शन लगा देंगे ठीक हो जाएगा. This is not a 3 month disease. It's a long term disease, 2-3 year disease. In the first 6 months, you have to keep injecting until the patient gets 20/20 vision or 6/6, or the edema completely dries. But beyond 6 months, you can have some relaxation. Some relaxation. You don't have to inject every month beyond the 6 months. After the first 6 months, you inject even if there is edema. You don't have to inject all patients. You inject if there is a loss of 1 line, that is, patient has edema. If we remain 618, 618, 618, you don't have to inject. But if the patient worsens from 618 to 624 with edema, then you start re-injection. And the number of injections in 2 years, I can't even interact with you. But do you know what is the number of injections in these protocols over 2 years? 15 injections. 15 injections have to be given in 2 years as per the protocol, which our patients cannot afford, our doctors also cannot tell the patient so. So what are the alternatives? We have alternatives like Ozurdex. Ozurdex has slightly less gain in vision, especially in phakic patients. As we can see in this right side graph, pseudophakic patients, they maintain their improvement, but phakic patients keep on losing vision after initial gain because of cataract. But the mean injections is only 4.1 in 3 years. 4.1 injection in 3 years, whereas in anti-VEGF injection, the mean injection is 15 injections in 2 years. So it's a huge benefit if patients can be switched to Ozurdex later on after initial anti-VEGF injections. The other new injections are brolucizumab and faricimab, which have slightly longer effect. And the Indian guidelines published by Dr. Das and others clearly mention that anti-VEGF injection is the first line of therapy. I'll present one case and then conclude. We have had a patient, 67-year-old, who was we had visited our MTC campus in Bhubaneswar in December 2022. Blood pressure, diabetes, she was irregular with her medications. She had past history of cataract surgery. Now, this is a red flag. Whenever we do cataract surgery in diabetic patients, we should be worried. We should inform the patient the edema can increase or edema can come. So this patient already had received Avastin and Ozurdex earlier, and when she came to us, she had 20/100 vision in the right eye and 20/40. You see this OCT, massive edema, 20/100 vision. Left eye also, you see the slightly less edema, but 20/40 vision. Remember what I told in my beginning of the presentation, if the vision is worse, they will gain more. If the vision is less better in the initial presentation, they will gain less. But having said that, other OCT biomarkers have to be considered, and this intraretinal cystic hyperreflective material or ICHRM is a poor prognostic marker. So this patient we referred to the physician, did all the blood tests, HbA1c, lipid profile. She was not on antihypertensive, she had stopped, and she also had neovascularization in one eye, that is the FA I had showed. So ultimately we did PRP in both eyes, but we repeated ranibizumab in both eyes, and there was some definite reduction in edema. Edema reduced, but it's still there. And in the this is the inset is the baseline where a lot of edema. Left eye edema is also slightly improved, but patient had to be given 3 more injections because the edema was still persisting. And ultimately, after 3 Ozurdex injections, we decided to switch to brolucizumab. This was almost 5 to 6 months after the patient came to us and had received 3 Lucentis or Excentric injections. With one brolucizumab, the edema went away in the right eye and also the left eye. So now what? After brolucizumab of one injection, is this going to be over? Think about it. Yes, brolucizumab worked, but it doesn't cure the disease, right? Patient will get back edema. So what happened after 2 months? Edema came back, and edema came back in the left eye. We had to repeat the injection. But at this time, you can start thinking of Ozurdex or some longer acting drug to maintain the edema long term, but the vision usually remains stable. Don't expect improvement after every injection. Patient will say, डॉक्टर साहब पिछली बार से इंजेक्शन में इंप्रूवमेंट नहीं हुआ. It will not improve every visit. It will come and hit one roadblock. It will remain stable after one point of time. But at least patient will not lose any more vision. What about laser? This is my last slide. Laser, why we know for PRP, PDR, proliferative diabetic retinopathy, PRP is very important, standard of care. Do not inject anti-VEGF alone for PDR patients. You will end up with problems, not immediately, but long term. And these are patients where actually laser has been done, but one patient has ended up with severe traction because of inadequate PRP. So please make sure that you cover the laser up to the anterior, up to the aura, and the other inset photograph I'm showing, laser has been done, but again very scant. This is the time to repeat the laser. Don't wait for problem before you start adding laser. So in conclusion, in DME, we generally start with anti-VEGF. It's a long-term disease. Please communicate with the patient, not about 3 injections. 2 injection, 3 injection, ठीक हो जाएगा? No. It is a long-term treatment, will require multiple injections. Switch in 2 to 3 injections and steroids for maintenance. Please get trained in both interpretation of OCT as well as intravitreal injections before you start giving. And systemic control, I like Dr. Das's presentation. I have never met him, I have not heard him earlier also, but thank you, Dr. Das, for that wonderful presentation on diabetes. I would like to thank my colleagues who have been a big pillar of support for all of us. And once again, congratulations to Nayandeep Netralaya, and we all look forward to your Platinum Jubilee soon. And hopefully, I will be there at that time. Thank you very much.
Thank you. Thank you, sir, for your very comprehensive talk on the management and investigations. Any questions from the audience? Sir, I would like to ask one question, like since we have now so many anti-VEGFs in our armamentarium, so according to you, like which should be the first choice nowadays if we are going to use anti-VEGF? Should it be aflibercept or should it be brolucizumab in the first go? Or should we still start with ranibizumab and then, start switching? If the patient can afford and we have to choose an anti-VEGF, so what should be the first choice now?
It's a very good question. It's a historical question, not a new question. But yes, there is an answer based on the evidence. If you look at all the anti-VEGF, and you mentioned the cost is not a problem. Cost is always a problem. But even if cost is not a problem, I would say at this time, IDEA or Vabysmo. both are equally to start off with, but idea I would say has definitely lesser cost. We can never say cost is not a problem, but between Eylea and faricimab, Eylea has a much lower cost, even though there are schemes available, and it is equivalent to Vabysmo. But if one doesn't work, we can always switch to brolucizumab or faricimab. But if, as you said, cost is not a problem, Eylea is the first option.
Okay, sir. Thank you. Thank you, sir. Thank you so much.
If time permits, can I just chip in?
Sure, sure, sir. Sure.
Thank you, sir, for appreciating me. One point which I was just thinking of is that when we talk of diabetes and the ultimate care, we always should join hands together for not only sugar control but also to control the entire complication, which includes eyes. Unfortunately, we also delve into the fancy world of using the latest drugs, not taking into account the pocket of the patient. Sir, you also recommend VGF of the latest, and you have already told that the number of injections goes down as you go up the ladder of VGF. But the pocket of the patient drains out. So the insurance company does not approve of our GLPA receptor agonist, which is the best in class as of now if diabetes and its complications are concerned. So how to just circumvent these economic issues in the best treatment of a very poor patient from a small village of Bihar?
Question. Thanks again for bringing that out. There are two parts to it. One is the anti-VGF and cost. The other is collaboration. And I'd like to answer both of them. Anti-VGF cost, with respect to cost of one injection, should not be looked at for the patient. The cost of treatment over 1 year or 2 years is what should be looked at. And if you look at that, there are multiple ways in which the cost comes down because of free injections being available from the provider themselves, and insurance has covered. And I would say that at this point of time, it's not necessary that you have to go for the latest or highest or costliest. I did not actually, Eylea is not the costliest drug, which I did mention. But among those, Eylea is somewhere in between and very effective also. In terms of collaboration, I would say that a lot of effort from RSSDI and the Endocrinology Society of India, I have been working along with VRSI. We have been able to collaborate tremendously in the last 3 years. There are other VRSI functionaries there. They would really recall how difficult it was. Insurance has now covered anti-VEGF injections. Many state insurance schemes cover it. And also in Ayushman Bharat, now diabetic retinopathy screening is reimbursable, not just for ophthalmologists, it's reimbursable for diabetologists, general physician. You can take photograph in your clinic as a diabetologist or physician and claim reimbursement for those patients directly. You don't have to come refer to an ophthalmologist. And that is picking up in a big way, and that is happening. And in the future, we need collaboration.
And sir, the role of adjunct laser will also reduce the burden of the injections. So micropulse laser also can be attempted in such cases. And what is your take? Like, what do you think about micropulse laser in diabetic macular edemas?
Thank you for that question. You are specifically asking about micropulse laser. I have been part, in fact, I have initiated a randomized control trial long ago on micropulse laser with anti-VEGF or anti-VEGF alone. Unfortunately, the results, originally when it had come, there was a lot of hope with those lasers, but now I would say that micropulse lasers are not considered to reduce the number of injections in DME. They are not being used in general by most practitioners.
Micropulse laser is not a new thing. In fact, when I started my fellowship, I'm talking about 1991, micropulse came that time. Okay. So, because what Dr. Raja says, uncertainty, you are not sure treatment endpoint. Okay, all these factors always come into play. It is going back and forth, back and forth, back and forth. Ultimately, we're still in the same situation. It's almost 40 years now I'm talking about. So again, fancy things coming out. People talk about even dye laser, multi-tuning dye laser. There are issues each one has, but somehow it did not work that way, because treatment endpoint is you never be sure, because unless you are these things.
So ultimately, our direct focal lasers will be the choice of adjunct
Yeah,
laser.
extrafoveal edema is there. I think still that's as a gold standard, because you are sure at least you have treated those focal things. But what I think bottom line matters is strict metabolic control. And this treatment, actually probably most of the treatment what we are doing is help us to keep things under control by time. And why you say 2 years, 3 years, 4 years, as your sugar metabolic control is settled down, and then by the time nature takes course, and we are holding on till that time, so all treatment probably help for that. Yeah.
Thank you, sir. Thank you so much, sir.
So, thank you very much, Dr. Raja Narayanan sir, for joining us online, and I hope that in the near future we will, be able to hear you not online, but in person. We'll see you very soon. Thank you very much for taking your time out and agreeing to, in fact, it was your suggestion that you can do it online. Thank you very much, sir. Thank you.
Thank you very much. Thank you.
Just please stay for the mementos. I will request our chief guest, Dr. Partha Biswas sir. पीछे का लाइट जला दो, पीछे का. सर आइए. I will request Dr. Partha sir to kindly hand over a memento to Dr. Sudhir Kumar, he is Secretary of IMA. And a memento for Dr. Navneet. He is another very busy physician and diabetologist. So kindly felicitate our moderators, Dr. Deepak Agarwal, very active vitreoretinal surgeon in Patna. And Dr. Shivani Sinha, she has been trained in Nayandeep Netralaya, Bangalore, and she has worked in IGMS for her senior residency. Now she is focusing only on ROP, or mainly on ROP. And to Dr. Vivek, another high volume surgeon doing lot of retina work in Gaya and Patna. Yes, he has. Yes, Bihar has become one. So thank you very much to all the dignitaries who have taken the time out to come to our celebration. बहुत सारे हमारे अभिभावक, सीनियर्स को यहाँ देख करके मुझे बहुत ज़्यादा खुशी हो रही है कि आपने इतना समय निकाला और हमारे साथ सेलिब्रेट करने के लिए आए.